Okay, good morning, everyone.
Good morning.
Good morning.
Morning. This is the Office of Health Strategy hearing. It's on the Certified of Need application filed by the applicant, Encompass Health Rehabilitation Hospital of Danbury, LLC. This is docket number 20-32392-CON. In the application, applicant seeks to establish a new healthcare facility. The application states that the applicant is seeking to establish a 40-bed chronic disease hospital providing inpatient physical rehabilitation care in Danbury, Connecticut. The public hearing before the Office of Health Strategies Health Systems Planning Unit is being held today on October 28th, 2021. Public Act 21-2, Section 149, effective July 1, 2021, authorizes an agency to hold a public hearing by means of electronic equipment. In accordance with the Public Act, any person who participates orally in an electronic meeting shall make a good faith effort to state your name and title, and if applicable, at the outset of each occasion, that each such person participates orally during an uninterrupted dialogue or series of questions and answers. We ask that all members of the public mute the device that they are using to access the hearing and to silence any additional devices that are around them. This public hearing is held pursuant to Connecticut General Statutes, Section 19A-639A, and will be conducted under the provisions of Chapter 54 of the Connecticut General Statutes. My name is Joanne V. Yondo. Victoria Veltri, the Executive Director of the Office of Health Strategy, has designated me to serve as the hearing officer for this matter, to rule on all motions and recommend findings of fact and conclusions of law upon completion of the hearing. Office of Health Strategy staff is here to assist me in gathering facts related to this application and will be asking the applicant witnesses questions. OHS may also ask the intervener witnesses questions. I'm going to ask each staff person assisting with questions today to identify themselves with their name, spelling of their last name, and their OHS title. And if we could start with Mr. Carney, please.
Good morning. My name is Brian Carney, C-A-R-N-E-Y. I'm a Certificate of Need Supervisor at the Office of Health Strategy.
Armand?
My name is Armand Clark. First name spelled O-R-M-A-N-D. Last name C-L-A-R-K-E. I'm a healthcare analyst at OHS.
Thank you. As already mentioned, the applicant here is Encompass Health Rehabilitation Hospital, LLC. The Danbury Hospital has been granted intervener status in this matter. The Certificate of Need process is a regulatory process, and as such, the highest level of respect will be accorded to the applicant, the intervener, members of the public, and OHS staff. Our priority is the integrity and the transparency of this process. Accordingly, decorum must be maintained by all present during these proceedings. This hearing is being recorded and will be transcribed. All documents related to this hearing that have been or will be submitted to OHS are available for review through our CON portal, which is accessible on the Office of Health Strategies CON webpage. In making my decision, I will consider and make written findings in accordance with Section 19A-639 of the Connecticut General Statutes. The CON portal contains the table of record in this case. As of this morning, exhibits were identified A through double D. And let me just, yes, double D is the last one on the portal, which was put up at 7:12 this morning. In accordance with Connecticut General Statute, Section 4-178. The applicant is hereby noticed that I may take judicial notice of the following documents. The State Facilities Plan, OHS Acute Care Hospital Discharge Database, Hospital Reporting System Financial Data, Bed Need Methodology, Hospital Reporting System Report 400, Hospital Inpatient Bed Utilization by Department, and All Payer Claims Database, also known as APCD, for the claims data. These documents are within the agency's specialized knowledge. Mr. Carney, in addition to the exhibits A through the D in the portal and the documents I listed as administratively noticed, is there anything else to enter into the record?
No, Attorney Ando, I'm not aware of any additional documents.
Okay, counsel, for the applicant, are there any objections to the exhibits as are in the record on the portal or the notice documents?
There are no objections to the exhibits in the portal. I would just note that I don't believe there's a revised table of the record that includes those later documents. The table of the record I'm pulling up stops at, I believe, Z, but all of the documents are in here through DD and there's no objection or to the notice documents. The only issue is that there is an unresolved request in Exhibit O that I know you said you deal with today, but otherwise no objection.
Who was the last speaker? This is the court reporter.
Oh, I'm sorry. I apologize. This is Jennifer Fusco, counsel for Encompass Health.
Yes, I'm sorry. Okay, then all exhibits are entered as marked as full exhibits. I would like to advise the applicant that we may ask questions related to your application that you feel you have already addressed. We will do this for purpose of ensuring that the public has knowledge about your proposal and for the purpose of clarification. I want to reassure you that we have reviewed your application, completeness responses, and pre-file testimony. As this hearing is being held virtually, we ask that all participants, to the extent possible, should enable the use of video cameras when testifying or commenting during the proceedings. Anyone who is not testifying or commenting shall mute their electronic devices. All participants shall mute their devices and may disable their cameras when we go off the record to take a break. Please be advised that the hearing recording continues during the break. So any audio or video not disabled will be accessible to all participants to the hearing. So I will try to remind everyone when we take a break and when we go to lunch, but that's the standard practice on the OHS hearings. So it's important to remember to do that. Public comment taken during the hearing will likely go in the order established by OHS during the registration process. However, I may allow public officials to testify out of order. I or OHS staff will call each individual by name when it is his or her time to speak, his or her turn to speak. Okay, regarding Exhibit O, which is applicant's request for technical correction of hearing notice. Under 19A 639A F2, OHS may hold a hearing. As noticed, OHS is holding this hearing. As such, the technical correction is denied. However, regarding 19A 639AE, the record speaks for itself. In Exhibit H, the Danbury Hospital made a timely request under 19A 639AE for a public hearing regarding this application. In Exhibit I, OHS notified the Danbury Hospital that would be holding a hearing. my ruling is not that 19A 639 AE does not apply, but that a technical correction is not going to be made, as the hearing notice is sufficient. 19A 639 AE, as stated in the statute, does require a mandatory hearing, as the word shall is used. Are there any other housekeeping matters or procedural issues we need to address before starting the technical portion?
Just that Sydney Willman needs, I believe Leslie Greer is going to give her the ability to co-host so that we can screen share during our presentation.
Okay, so I'll let Leslie, certainly if that's becomes an issue, Leslie can certainly
Okay.
jump in and let us know if we're having any problems with that. Yeah, I'm just going to turn my camera off for a second and put my shade down. I think there's a glare.
No problem.
So let me just see if that works out. Well, maybe if I just, oh, okay, hold on. Okay, now you get to see me and not the beautiful trees on Capitol Avenue.
It's better. We can see better. Thank you.
Okay, you're welcome. Okay, this time I'd like counsel for the applicant to identify yourself, please. And I'm sorry, I know you already did, but if you could do that again also.
It's okay. This is Jennifer Fusco from Updike, Kelly and Stellici, counsel for the applicant Encompass Health Rehabilitation Hospital of Danbury, LLC.
Great. And as previously stated, there is an intervener in this matter. Could I have counsel for the intervener identify themselves, please? And I do think for the court reporter, if you would spell your last names, please.
Yes, thank you. Good morning, Hearing Officer Yando and staff of the Office of Healthcare Strategy. On behalf of the intervener Danbury Hospital, this is Theodore Tucci, Tucci, and along with Connor Duffy, I represent the intervener Danbury Hospital. Also with us today is my colleague Lisa Boyle, Boyle, Mr. Duffy, Duffy. Thank you.
Okay, thank you. Okay. Attorney Fusco, do you have an opening statement?
I just wanted to sort of briefly introduce the project and my clients. So, thanks for this opportunity to make some remarks. As I said before, I represent Encompass Health Rehabilitation Hospital of Danbury, which is a subsidiary of Encompass Health Corporation, which is a leading national provider of inpatient rehabilitation services across the country. Encompass Danbury is before you today, as you've mentioned, requesting CON approval to establish a 40-bed inpatient rehabilitation hospital in Danbury. The state-of-the-art facility will serve a specific targeted patient population that's in need of this intensive level of inpatient rehabilitation services, which I think we're going to learn a lot about today. But they're services that address significant health conditions such as stroke, multiple trauma, spinal cord, and brain injuries, just to name a few. You are going to hear testimony today about a needs assessment that was done that identified what we refer to as a significant gap in care for these services in the service area and in Connecticut generally, and that forms the basis of our CON request. You're also going to hear testimony about how the proposal is going to improve the quality, accessibility, and cost effectiveness of care as is required by the CON statutes. The proposed hospital is going to be of tremendous benefit to Connecticut residents whose ability to recover from serious illnesses and injuries and regain functionality relies on there being adequate access to these types of enhanced rehab services. So Our presentation is going to take a while, so I'll stop talking and introduce to you our witnesses. You're going to hear today from, first from Patrick Tour, who's the Northeast Region President for Encompass Health. You're going to hear from Dr. Elisa Charbonneau, who is the Chief Medical Officer of Encompass Health, and you will hear from Marty Chafin, who is the President of Chafin Consulting Group. Marty is here with me today. Mr. Tour and Dr. Charbonneau are remote. And we sound check them, we should be fine. Mr. Tour's up now. So thank you again for your time, and I'll turn the presentation over to Pat.
Okay, so what I will do, since we're going to take these, witnesses separate, I will swear them in separately. So we'll try to, I just want to keep with your flow. Also, the intervener will be allowed an opening statement, but I will, that will be after the applicant is done with its presentation. So I did want to make, the intervener aware of that. Okay. Okay, so Mr. Patrick, is it Tour?
That's correct.
Okay. And you filed a pre-filed statement, is that correct?
That is correct.
Okay. Could you please raise your right hand? Do you solemnly swear that the evidence that you're about to give today and the evidence and statements you gave in your pre-filed testimony are the truth, the whole truth, so help you God?
I do.
Okay. Thank you. And again, state your name for the record.
My name is Patrick Tour. Last name is spelled T-U-E-R, and I'm the regional president for the Northeast region of Encompass Health.
Okay, well, you can go ahead and offer whatever evidence is that you want me to consider today.
Great. Thank you, Attorney Yondo, and members of the OHS staff. Again, my name is Pat Tour, and I adopt my pre-filed testimony. Thank you for this opportunity to testify in support of our certificate of need application for permission to build a 40-bed inpatient rehabilitation hospital in Danbury. This hospital, if approved, will fill a substantial unmet need for inpatient rehabilitation services in Western Connecticut, ensuring that patients have adequate access to high-quality care that is suitable to their health needs. In my role as president of the Northeast region of Encompass Health, I oversee 19 inpatient rehab hospitals in states, including Pennsylvania,
This
Massachusetts.
is the reporter. I apologize for the interruption, but you are fading in and out. I'm sorry, but I'm having difficulty hearing you.
Okay, where did I cut out? I'm sorry.
I was getting it. It's just you're fading in and out. It sounds like you're moving forward and back from the microphone.
Okay. Let me move this
Yeah,
one.
we haven't missed anything, but it is,
Okay.
it's not consistent. Attorney Fusco, do you agree that, are you getting the same type of audio?
We are, and it may just be, Pat, that you need to lean a little forward and closer to
Yeah,
the
I'll do that. Is this better?
Much better.
So in my role as president of the Northeast region of Encompass Health, I oversee 19 hospitals, inpatient rehab hospitals located in 6 states, including Pennsylvania, Massachusetts, Maine, New Hampshire, New Jersey, and Delaware, with a combined employee count of 3,300 FTEs. Before becoming president of the Northeast region, I served as vice president with the company since 2018. And in these roles, I've gained knowledge of the market for inpatient rehab services in the Northeastern US, where Encompass has a significant presence. Excuse me. Encompass is a national leader in inpatient rehabilitation services with 144 inpatient rehabilitation hospitals located in 35 states and Puerto Rico. We are the nation's largest system of rehabilitation hospitals and the trusted choice of medical professionals in the communities that we serve. At Encompass, inpatient rehabilitation is what we do. One of our primary purposes is to own and operate post-acute care facilities like the one being proposed in Danbury. Encompass is committed to delivering connected care and superior outcomes for its patients. We bring to local markets the resources and experience of a national company specializing in inpatient rehabilitation that has proven high quality, cost-effective programs and services, along with the financial strength to ensure that our patients and especially trained staff have access to an extensive array of rehab-specific equipment and technology. Although I was not involved directly with the planning of this project because it predated my time as the Northeast Region President, I will be responsible for operationalizing and overseeing the Encompass Danbury Hospital if this CON is approved. We don't take entry into a new market lightly and would not propose a project like this without confidence that the level of rehabilitation services we provide are needed by the residents of this area. In addition, you will hear from our consultant, Marty Chafin, who conducted the needs assessment that identified a significant gap in care for inpatient rehabilitation services in Western Connecticut. As you will hear, inpatient rehabilitation utilization in the service area is well below the national average, due largely to a lack of inpatient rehabilitation beds, which the proposed Encompass Danbury Hospital will address. You will also hear today from Encompass's Chief Medical Officer, Dr. Lisa Charbonneau, who will discuss the programs and services that we will offer at the proposed hospital and how it will be staffed, designed, and operated to achieve superior outcomes for patients. We are excited for this project, which will enhance access to high-quality, cost-effective inpatient rehabilitation services in an area where they are very much needed. We will bring the strength of a national healthcare company that implements proven, high-quality, cost-effective programs to the market. At the same time, we will establish local relationships with providers and organizations that will ultimately benefit service area residents in need of this enhanced level of rehabilitative care. For these reasons, I urge you to approve our CON application. I am available to answer any questions you have once our presentation is concluded, and I will now turn it over to my colleague, Dr. Charbonneau. Thank you.
Thank you. So I just want to make any kind of cross-examination and questions. We will wait for the end of the presentation. So we will go ahead with Dr. Charbonneau.
Thank you so much. Can you hear me okay and see me okay?
I can. Please, and did you file a pre-filed testimony?
Yes, I did, and I adopt my pre-filed testimony.
Okay, can you raise your right hand, please? Do you solemnly swear that the testimony you're about to give and the pre-filed testimony that has already been put in the record is to the best of your, is true and factual to the best of your belief, and is the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Okay, and do you adopt your testimony that was pre-filed?
Yes, I do.
Okay, thank you. You can go ahead. Could you
Thank
just
you.
spell your last name for the record?
Yes, it's a long one. It's
You might want to
Charbonneau.
spell your first name too, because I think there
Yeah.
you might get some different spellings.
Yes, my first name is Alyssa, Elissa, and the last name is Charbonneau, Char, B as in boy, Onneau.
Okay, thank you. You can go ahead.
Good morning, Attorney Yandro and members of the OHS staff. My name is Dr. Alyssa Charbonneau, and I am the Chief Medical Officer for Encompass Health Corporation. Thank you so much for this opportunity to testify in support of our CON application to build a state-of-the-art inpatient rehabilitation hospital in Danbury, Connecticut. As a resident of Maine, I'm especially excited by the prospect of expanding our footprint into another hospital in New England. I really believe that this hospital, if approved, will fill a significant unmet need for inpatient rehabilitation services in the area and will provide high quality, cost-effective care as we do in all of our facilities across the country. It will allow residents of this service area to access much needed inpatient rehabilitation close to home, where their families can help support them as they're recovering from some significant injury or illness. Encompass, as you heard from Patrick Tuer, is a national leader in inpatient rehabilitation services and the trusted choice of medical professionals in their communities all over the country. An inpatient rehabilitation hospital or inpatient rehabilitation facility, which is usually referred to as an IRF by CMS, the initials IRF, is a hospital with a high intensity rehabilitation service. And this meets the needs of people who have had some type of life-changing injury or illness And as a result of that injury or illness, they've had a significant functional decline. And due to the combination of their medical needs and their rehabilitation needs, they're best served in an inpatient rehabilitation hospital or an inpatient rehabilitation facility. The kind of patients that we take care of in our hospitals are patients who have had significant strokes, spinal cord injuries, brain tumors, amputations, and other diagnoses. If this project is approved, patients will benefit from our expertise in building, staffing, and operating an inpatient rehabilitation hospital. This is our specialty, and this is what we do. Just to give you a brief background, I've been the Chief Medical Officer of Encompass since 2015. And in this role, I oversee the clinical quality for our 144 inpatient rehabilitation hospitals, as well as our network of home health and hospice agencies. I also head up a medical services department, which is a department that is solely dedicated to physician education to improve our quality, our compliance, and our delivery of care in our hospitals by the physicians that practice there. I also oversee our quality reporting program. The focus of my remarks here today are twofold. First, I will provide an overview of an Encompass hospital to give you a sense of what patients and their families would experience during a stay at the Encompass Danbury facility. We will provide an enhanced level of rehabilitation in that facility with highly specialized staff and who are trained specifically in rehabilitation and advanced rehabilitation equipment. Our hospitals are all very patient-centric, and I think you will get a good opportunity to see what I'm talking about. Second, I will talk to you a little bit about why the post-acute care setting, where many Connecticut residents appear to be getting their rehabilitation services right now, are less than optimal. Skilled nursing facilities and non-IRF chronic disease hospitals are very different than an inpatient rehabilitation hospital. And this includes the way that they are staffed and their physical appearance as well. As noted in my written testimony, the success of Encompass's hospitals nationwide is really due to our comprehensive team approach to rehabilitation services. And we use the latest technology and treatments using evidence-based medicine to make sure that we're providing the highest quality of rehabilitation care for our patients. Let me highlight a few ways in which the staff at the Encompass Health hospitals work together to benefit our patients. Our hospitals, first of all, have an open staff model. That means that community-based physicians are available to care for patients' specific needs alongside and in addition to rehabilitation physicians who have specialized training in rehabilitation like myself. This results in enhanced patient access to medical specialists and a seamless transition back to the community so that they can follow up with their care providers in the community after they leave the rehabilitation hospital. We also really pride ourselves on our specialization of our rehabilitation nurses. So our nurses have special training in rehabilitation medicine and are continually being trained and certified through our association with the Association of Rehabilitation Nurses. And many of them have a special certification in rehabilitation nursing. We also have teams of therapists, including physical, occupational, and speech therapists, along with nutritionists, on-site pharmacists, who all work together to make sure that our patients and their families have a good understanding of the care and of how the patients are progressing in their rehabilitation and how they can best transition to home. All of our patients are assigned a case manager. The case managers work very closely with patients and their families to ensure that their needs are met both during and after therapy, and they coordinate the discharge into the community and the follow-up care that the patients will need. So our goal is really to get patients home successfully and to keep them home so that they don't wind up back in the acute care hospital. Many of our hospitals have what's called disease-specific certification from the Joint Commission. This requires significant additional training and expertise in specific areas, for example, stroke. And I have every expectation that our hospital in Danbury will also receive disease-specific certification in stroke and other diagnoses, depending on the needs of the community. In addition to our unparalleled staff, our hospitals also provide a comprehensive array of inpatient rehabilitative services. And this allows us to treat patients who have had profound functional deficits from stroke, traumatic brain injury, spinal cord injury, amputations, multiple trauma, orthopedic injury, cardiac episodes, pulmonary issues, to name a few. And all of our patients, we strive to make sure that they have superior and successful outcomes from their rehabilitation when working with our team. Our patients also benefit from a patient-centric approach to treatment. So for example, we have a no pass policy. So we train our staff that if they pass a patient room and a bell is on saying the patient needs assistance, that they respond to the patient regardless of what their role is, even if they're a housekeeper and not necessarily a clinician. We have an in-room information board that's very useful for our patients and their families, so they can come in and see what the patient's schedule is that day, who their physicians are, how they transfer, what kind of food are they allowed to eat, and so forth. Some of our hospitals have a victory bell, which they ring at discharge, and we have staff lining up in the hallway to applaud patients as they are successfully leaving our hospital. Finally, all of our Encompass Health hospitals are really designed with the needs of the medically complex patient. And this is a big difference, and I've worked in skilled nursing facilities. These Encompass Health hospitals are really a hospital environment where we can treat patients who need IV medication or dialysis or other complex medical treatment. So I think now what we would like to do is take you on a virtual tour of one of our flagship hospitals. Are you able to see the screen okay?
Yes.
Yes, I can see it.
Okay, so we will be starting this tour in the parking lot. And as you can see, you will drive up to the front of the building where there's adequate parking and also handicap parking for visitors and others. And then we would walk into the main entryway of the hospital, where we have a reception area. And this is where we're currently doing our COVID screening, by the way. So we screen all of our visitors to make sure that they don't have any symptoms of COVID-19 or any fevers. And then we would progress down the hallway, and we will take you into our gym area. We'll come back to this area in a second, but here you can see right in front of you, this is a simulated automobile. So this is where we practice with patients getting in and out of a car, and we can raise and lower this device so they can practice depending on whether they need to get into a sedan or an SUV, for example. And as we pass through the gym here, you can see our large gym area with all this different technology available. Here we have some stairs where the patients can practice going up and down the stairs. And overhead, you can see that there is a body weight supported harness that for patients that are not able to stand unsupported. We have tracks in the gym, and they can be put in the harness, and they can practice ambulation and stair climbing, etc. As we look around the gym, you can see there's various different types of equipment, and we have the latest and best technology for our therapists to work with the patients to ensure that we're using every tool that we can to help them. For example, over the treadmill on the back right-hand side, there is something called a light gate. That is a body weight supported harness that allows the therapist to work with the patient while they're walking on a treadmill and practice their ambulation while they're being supported with as much as they need to be supported by this device. Then you can see we have our parallel bars. We have some other technology here to the right, which works on different skills such as balance. This is a balance practice device. And if we continue to go over towards the right in that area, that looks like there's a background there. That is actually a one-way window where behind that our therapists are doing their documentation while they're still able to look out with a one-way window and see how patients are doing in the gym. And if we go over to the right, you'll see what's called an ADL suite, which is an activities of daily living suite. So this is an area where as patients are getting ready to be discharged, they can practice in what looks more like a studio apartment with a regular bed, a kitchenette area. They have laundry facilities so they can practice doing laundry and cooking and other skills that they'll need when they go home. So I think next we're going to take a tour of the outside area. So this is a courtyard, and the great thing about our courtyards is they have various different surfaces for patients to practice walking on. So cement, wood, gravel. We also have outdoor stairs for them to practice on and a ramp if they are wheelchair users, so they can practice going up and down the ramp in their wheelchair. And in the summer, we also have gardening skills for the patients to practice gardening if they're interested, and other activities that they can do outside. Here we have one of our patients' rooms, and what you see here is a whiteboard that all of our patients' room have, which helps the patient and the family, as I mentioned earlier, understand who their treating clinicians are, who their physicians are, what their schedule is for the day, their goals, how they transfer in and out of bed, and some questions about pain. You can see on the lower left-hand corner where we make sure that we're addressing pain issues as well. And each of our private rooms are wheelchair accessible with a private bathroom as well. I should also mention that we have bariatric rooms, so we don't have to rent equipment for bariatric patients that need special size equipment. When they come into the rehab hospital, we're just ready for them and we put them in a bariatric room. This is our cafeteria area for our staff and visitors to use. And you can see there's a lot of natural light in the building. It's a very nice environment for patients to get rehabilitation. Okay, and then this is just our typical nurses station. So the nurses stations are located centrally, so they have good access and visibility for the patient rooms. And in that area behind the green, you can see where our clinicians can do their documentation on the computers, and all of our hospitals are on an electronic health record, which we have worked on for many years with our partner, Cerner, to make an electronic health record that is very rehab specific. So I think that you can see that we have to the right here, we have a day room. That's where different team meetings can occur. So all patients in an inpatient rehabilitation facility are required by Medicare to have a weekly team conference where the team gets together and discusses the patient's progress and how they are doing and their progress towards their goals. And in this day room is one area where we can have these conferences. This came in very handy during the pandemic where we had to socially distance. So It's a nice big room where we can have different meetings and activities for patients and their families as well. Okay, I think that concludes our virtual tour. Thank you. I want to just add that all of our patients, as you saw in the gym, really benefit from specialized technology. And in order to make sure that we are, there's a lot of technology out there. We want to make sure that we're using technology that really is useful for the therapist and the patient. So we have a clinical technology investment committee, and we vet all new technology that we're interested in, and we trial it in some of our hospitals before we make a big investment in technology, so that we can make sure that we're using technology that the clinicians feel are very valuable to the patients. We also have a TeamWorks initiative, which improves quality of care through standardization and implementation of best practices across all of our hospitals. So we have a way of standardizing our admissions procedure, for example, to make it very seamless and easy. We also have a patient safety task force, which works to identify and implement improvements, processes, and policies to increase patient safety and staff safety. So to reduce, for example, back injuries for nurses that have to transfer heavy patients in and out of bed. And we also have our own internal patient safety organization, a PSO, to collaborate and develop safety solutions. We have a very unique post-acute innovation center that was established in 2017. And that's in partnership with Cerner Corporation, which is our partner for our electronic health record. And our innovation center has worked to develop predictive algorithms based on our own in-house data, because we have had our electronic health record for so many years, and we have so much data and so much information on our own patients that we've been able to develop predictive algorithms to improve clinical care for our patients. For example, reducing acute care transfers back to the acute hospital and reducing readmissions after discharge from the rehab hospital. And we're currently just about to rule out a fall reduction predictive algorithm. So I'm very excited about that as well. We also have a national partnership with the American Heart Association, American Stroke Association, and we're working on their initiative to end stroke, and we participate in various activities in different communities with outreach and other activities to reduce stroke and increase stroke awareness and education. We also engage in primary research to improve practices and protocols for various diagnoses. We also have many clinical teaching affiliations throughout the country with universities, colleges, and technical schools, and we're really working hard to address the nursing shortage across the country in some of our work with our partnerships with different schools. So thanks to the exceptional care that our staff provides our patients, and utilizing this excellent and best equipment and technology that we have, our patients experience superior outcomes. And I'm very proud to say that Encompass has a track record of returning approximately 81% of patients directly back to the community, which really outperforms other providers of inpatient rehabilitation nationally. And finally, I would be remiss if I didn't end my remarks about the quality of care at Encompass with regard to COVID-19. So throughout the unfortunate pandemic, we have found that we have been able to care for individuals recovering from COVID-19. And in doing so, we have been able to help relieve some of the overcrowding in the acute hospitals by taking on these patients with very significant medical needs, and also needs for rehabilitation very successfully. And we've treated at this point over 16,000 patients recovering from COVID-19 in our hospitals. And I think what this has really highlighted for us is our ability to care for and take care of patients with significant medical needs, as well as assisting our acute care hospital colleagues in helping them to discharge patients so that they can focus on patients who really need to be in the acute care hospital. So in summary, Encompass leverages its demonstrated best practices, proven staffing models, comprehensive information technology, centralized administrative functions, supply chain efficiencies, economies of scale, and its sole focus and commitment to the healthcare industry to ensure that its community-focused local hospitals consistently provide the highest clinical outcomes. And just to highlight, I would like to provide OHS with information regarding the different levels of post-acute rehabilitative care and why they are really not interchangeable. We know from our needs assessment, which my colleague, Ms. Chafin, will discuss, that Connecticut residents have a disproportionately low utilization of IRF services and a disproportionately high utilization of skilled nursing services or SNF services. SNF is not an appropriate substitute for patients in need of intensive inpatient rehabilitation. They don't have the same level of nursing and physician oversight. We are required by Medicare for our patients to see a rehabilitation physician, a patient with specialized training and experience in rehabilitation, a minimum of 3 days a week. And in addition to that, most of our patients also see a hospitalist or an internist and a rehabilitation physician every day or almost every day in our hospital. So the 3 times a week visits by a rehabilitation physician are a minimum requirement that we exceed. The higher level of care provided in an IRF versus a SNF is one of the reasons why IRFs have a significantly higher rate of discharge to community, overall 76% nationally, compared with 40% for SNFs versus return to an acute care setting, such as a general hospital. I can tell you from my many years of experience as a rehabilitation physician working in the IRF setting, that the worst outcome for a patient who's just recovering from something significant like a stroke while they're in rehab is to get sent back to the emergency room or sent back to the acute care hospital. So our processes and our quality of care are all geared towards the goal of getting patients home back to the community. And that's why we have so many programs and protocols to help keep patients in the IRF until they're ready to go home and get them home. Physicians in the Danbury community have voiced the need for specialized care provided by IRFs, which they cannot get consistently in SNFs in their letters of support for this proposal. Connecticut's non-IRF chronic disease hospitals are also not appropriate substitute for IRF services. Existing CDHs offer different types of services and treat different patients, as evidenced by staffing, facility design, and equipment. They're also paid differently than IRFs by Medicare based on this type of level of service that they provide. I hope this information has helped you and OHS understand the ways in which Encompass hospitals are designed, staffed, and operated to ensure access to the highest quality of inpatient rehabilitation services for these patients who need this enhanced level of care. I urge you to approve Encompass Danbury CON application, and in doing so, allow us to fill the unmet need for inpatient rehabilitative services in Western Connecticut with a state-of-the-art, beautiful rehabilitation hospital that provides the level of care needed by so many patients who today are not receiving that level of care. I'm also available to answer any questions that you have once our presentation is concluded, and I will now turn it over to Ms. Chafin.
Hey, Dr. Charbonneau, I'm just going to ask you a few questions, and we're going to, when the whole presentation is done, you will, probably get some cross-examination questions from the intervener and also some questions from the OHS staff. So I just have a few questions just on the top of my head that I just kind of, but this may get explored a little bit more later. But when you're talking about like the Connecticut, the need, for Connecticut and where they go, the skilled nursing facilities, where are you getting that information from?
I think Ms. Chafin is going to go into that in much more detail.
Okay. And as far as, when you say the need, the need that's there in Connecticut. Can you tell me what you're basing that on when you say with the need? I mean, what you're looking at?
So what we know from what is going on in Connecticut is that there are just not there's not a sufficient number of inpatient rehabilitation facility IRF beds to serve the population based on demographics and other things that I think Ms. Chafin will explain in better than I can. But so it stands to reason that based on what we're seeing in Connecticut, patients are just either going to nursing homes after their acute hospital stay, or they're going home with home care, or they're not getting rehabilitation at all. And I really believe that there are, and we know this just based on, how we receive referrals from patients all over the country, that there are patients who are recovering from significant medical and injuries, medical issues and injuries that are just not able to get IRF level services in Connecticut. So they're either not getting them at all, or they're going out of state, or they're just missing out on this specific level of care with this specific level of expertise to treat these types of injuries in this particular setting. It's just not available in Western Connecticut.
Okay, thank you. And we'll probably follow up with some more questions a little later, but
Okay.
but thank you very much. Okay, I
Thank
guess Ms. Chafin. Is Ms. Chafin on?
She's here with me.
Oh, hello, Ms. Chafin. You filed pre-filed testimony, is that correct?
Yes, I did.
Okay, could you raise your right hand, please? Do you solemnly swear that the testimony you're about to give and the pre-filed testimony that's already in the record is the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Okay, do you adopt the testimony that was filed?
Yes, I do.
Okay, and could you spell your first and last name, please, for the record?
Yes, I'm Marty Chafin, MartyChaf as in Frank, IN. I'm with Chafin Consulting Group. You can tell, probably located in the South, based in Georgia. I want to walk through the exhibits that were part of my pre-filed testimony. I will do that in just a minute, but I'd like to, before I do that, do two things if I can. One is to talk about my role in this process, and the second is to give a brief overview of my background. I was contacted by Encompass Health to confirm that Connecticut in general and Western Connecticut specifically has a need for beds. Based on the research and the knowledge of Encompass, they felt that was the case. They asked me to confirm that, and if I agreed with that, to quantify that. The result of my analysis, along with my colleagues at Chafin Consulting, is a CON application and the completeness response. So that was my role in the process. In terms of my background, I have been in healthcare since I graduated from Georgia Tech. So I have 34 years of experience only in the healthcare industry. I always worked in healthcare. In terms of the client scope, I have worked with academic medical centers all the way to small community sole providers. I have worked with ambulatory surgery centers, radiation therapy providers. In terms of post-acute care providers, I've worked with all four. You'll see later in the exhibits that there are 4 post-acute care. Inpatient rehab, as we're talking about today, home health, skilled nursing facility, and long-term acute care. So I have worked and developed CON applications for all 4 of those. As an expert witness, I have testified in Georgia, Alabama, Mississippi, Tennessee, and Oregon. I have also presented to Illinois and Rhode Island state boards. Beyond that, I have worked geographically on CONs, and I guess I should say, this makes me sound old, but I've worked on hundreds or been involved in hundreds of CON applications in my 34 years. So beyond the states in which I've testified as an expert witness, I have worked on CON applications in Florida, North Carolina, South Carolina, Kentucky, Virginia, and Delaware. And then beyond that, I've worked on healthcare projects in Massachusetts, New Jersey, Texas, California, Washington, and Alaska. And then finally, if you can imagine this accent, in the Middle East, I worked in Qatar, QATAR, working with the Supreme Council of Health to develop a regulatory framework so that they can analyze and assess the need for programs and services much as we do in the United States. So I'm gonna bring it closer to home now. Coming back to the exhibits, if you'll put those up, Sydney. The presentation begins with the state analysis. You just asked a question, Attorney Yondo, of how do we know that patients are going to skilled nursing? And so I will get to that in a few minutes in terms of the specific data that shows that in Connecticut, patients are disproportionately utilizing SNF compared to IRF. That's one way, is we have the data. The second way that we know that is physician letters. In the CON application, there are physician letters and providers, for example, from Brain Injury Alliance. Dr. Peter McAllister is a neurologist. We have Dr. Bueno, who is an anesthesiologist, and Dr. Gray, who is an orthopedist. They have all discussed that there is a need for this proposed project, and some of those letters address that when patients are going to SNF, there are suboptimal outcomes and inconsistent care, and the patients would benefit from the intensive inpatient rehab services Encompass is proposing. So I wanted to answer your question before I go through the exhibits. The exhibit in front of you, can everyone see the exhibits? I guess is the question. Okay. The exhibit in front of you is for Connecticut. All of the data that I'm referencing is publicly available. So my approach is there's no black box. There's no secret. This is full transparency. You may not agree with the conclusions that I'm drawing from the data, but the data is what it is, and it's publicly available. The information that I will present when I talk about Medicare data is Medicare fee-for-service information. I want to be very clear based on the information from the interveners that that does not mean Encompass is only serving Medicare fee-for-service patients. What it means is that Medicare fee-for-service data is available, and that when you look nationally, Medicare fee-for-service is the primary user of inpatient rehab facility services. So it makes sense that I'm going to use publicly available data, and that publicly available data represents what is happening because it's the primary user of this service. So Medicare, when I reference it, is Medicare fee-for-service unless I say otherwise. Exhibit B is the first time that you'll hear me use the phrase gap in care. What you see, the states are listed along the x-axis. So you have vertical lines that show for Medicare fee-for-service patients that go to the hospital, what percent of those patients are discharged to inpatient rehab facilities? As Dr. Charbonneau said, IRF is how CMS and we reference it. The national average is the black horizontal line. 4.22% of Medicare patients that go to an acute care hospital are discharged to an IRF. In Connecticut, which you see is red, 1.64% of your patients are discharged to IRF. I call that, from a health planning perspective, a gap in care. You see that nationally, Connecticut ranks among the lowest. You are 48th out of 51, because this includes DC, 48 out of 51 states in terms of the lowest number or percentage of your discharges to inpatient rehab. North Dakota and Oregon are below Connecticut. What's important, I think, is to recognize that in Oregon, 100 beds have been approved because they recognize that gap in care needs to close. For North Dakota, 59 beds are in process. Either they have been built or will be built. My pre-file testimony, I believe, says 42. That's because since then I have been aware that 17 additional beds are going to be added. So those states are recognizing and beginning to close that gap in care. In terms of perspective, Connecticut is, I guess I should say it this way, the national rate is 2.5 times greater in terms of the percentage of Medicare patients discharged to IRF than you see in Connecticut. If you look at the next slide, this is 2020 data. This was not available at the time the application was filed, so I have updated it. The result is the same or maybe a little bit worse. And what I mean by that is the gap in care has increased. Connecticut as a whole still is 48 out of 51 in terms of the lowest percentage of Medicare patients being discharged to IRF. What has happened at the same time that
This is the reporter. I can't hear anyone.
I recognize 2020 data.
Okay, I just want to, for a moment there, you were frozen. So I don't think anything got recorded. I don't know if you want to go back just a few seconds. I don't know if you started a sentence or something. I don't know if you were having problems, Attorney Fusco, but the court reporter and I both, it seemed to be that your screen and your audio, everything was frozen for a few seconds.
Yeah,
Hopefully it was just
we just got a notification that our internet connection was unstable, but it seems to have cleared. You can hear us now, right?
Yes.
Okay, so maybe go back a sentence or two.
Yeah, just if you want to make sure that the record has whatever you want in it, although I'm sure, you know, most of it is in the pre-file. We probably missed about 15 seconds. You're frozen again. I guess, well, I guess until she tells us they're back on.
Now we're back now.
Okay, when you're
Okay.
frozen, can you hear me?
No,
You can't.
not at all. Everyone's frozen. Okay.
All right. Okay, so hopefully that's just temporary. So
We'll get some tech folks in just to make sure, but for now
Okay.
you can.
all right, well, let's continue. If it gets too bad, we'll take a break and then you can bring your people in to see if there's a fix on your end. But why don't we go ahead and continue? Like I said, we probably lost about, you know, the beginning of a sentence or something if she needs to back up at all.
Okay, I'll just make three points on this slide. The gap in care is increasing, meaning that the US average has increased, whereas Connecticut has remained relatively flat. So the US average is 2.8 times Connecticut. Connecticut still ranks 48 out of 51 in terms of the low.
This is the reporter. She just cut out again.
Joanna, I think you're on mute.
Sorry. Yeah, let's just see if they come back in a couple seconds. And then,
percentage of Medicare
okay, you
conversion
were
rate of
frozen
those-
again. Attorney Fusco, I don't want to like stop the flow, but would it be, you are in and out now. Would it be helpful if we took a short break to work on, to see if you can get your glitch fixed? I don't know what just happened. Brian, can you hear me?
Yes, I can. I think they're frozen. Although they actually just left.
Recording in progress.
Hi, this is Sydney Wellman.
I'm not sure who Sydney Wellman is.
Sorry, I'm with the Encompass
She's on their
team at
team.
Encompass
Yeah.
Health, and I just wanted to let you know we're having problems with our screen, our large conference room capabilities. If we could take a break to get some tech people in here, we would very
Yes.
much appreciate that.
Okay, so it's about 11:08. Would 10, 15 minutes? How long do you think? Let's come back at 11:25.
That would be great. Thank you so much.
Okay, everyone, please remember that there is the recording goes, when we are on breaks, our recording continues. So please shut your audio off. You may want to shut your video off. That one I'll leave up to you, but we will be back at 11:25. Okay,
Thank you very much.
Yeah.
Somebody
We are not. We're back. We're back on. Can you guys hear and see us fine?
Yes.
I can hear you.
We can see you all moving around. I see Ted waving, so hopefully we fixed it. We're so sorry.
Okay, let me just make sure we're back a minute early here. I just, is the intervener or all set, ready to go? Attorney Tucci, all set? Okay, all right. Okay, this is how it works in the remote hearing world these days. You know, we just have to make do, and I'm glad you're all back on. So, Ms. Chafin, if you want to pick up where you left off, that will be great.
Okay, thank you. Page 2, Sydney, is that where you're headed?
Yes.
Just for the record, I'll make sure that the 3 points I'd like to make, I can, hopefully with no technical difficulty. One is that the gap in care has increased when we look at 2020 Medicare data compared to 2019. The US average percentage of Medicare discharges to IRF as a percent of total Medicare discharges has increased, while Connecticut has remained relatively flat. So that means the US average is 2.8 times Connecticut. Connecticut remains at 48 out of 51 states in DC. And in 2020, I do put that information forward with the caveat that it is the full year of COVID. But since I am looking at state level data, I feel that it is an appropriate benchmark because every state, my assumption and my knowledge in the industry is every state has been impacted pretty much equally in terms of the COVID. It may have been different months, but there was an impact for all hospitals in all states.
Well, let me just ask you, and I don't mean to interrupt, just because you brought that up and I'm looking at this. So so these numbers here involve COVID. So do we know, how many percentages of each of these are COVID patients? Because I don't know if part of your research shows Connecticut versus other states, regarding COVID.
I do not have that information. I know that the patients went to IRF, but I do not know the diagnosis with which they entered IRF. And one of those would be whether or not they had COVID. I do not have that information.
Okay, all right, thank you.
Next slide. Still looking at Connecticut as a whole, whereas the prior 2 slides were Medicare fee-for-service beneficiaries that left a general acute care hospital and went to an IRF. Now we're just looking at Medicare beneficiaries. We're not worried about yet if they were in a hospital or not, because I want to compare what happens per 1,000 beneficiaries in terms of, to Dr. Charbonneau's point, are some patients going to SNF or some patients going to IRF, and how does that compare? And Attorney Ondo, you asked, how do we have the data and how do we know about patients going to SNF? This is where we begin to see that data. And what the data shows in front of you is the ranking nationally in terms of highest to lowest IRF discharges per 1,000 Medicare beneficiaries. Connecticut in this ranking is 43rd. However, when you look at the SNF discharges, which is 95 per 1,000 beneficiaries, Connecticut ranks #1 in the nation. And that 19.0 is a ratio of SNF to IRF to give us order of magnitude to see what does it look like in Connecticut, the ratio of SNF to IRF discharges for Medicare patients compared to the US overall. And that national average is that last line you see, 5.8. So this is where Dr. Charbonneau was talking about, we know patients are going to SNF and we know they're doing that disproportionately. If you look at the next slide.
I don't mean to interrupt, but just why these are on my head, and I think probably, one of our analysts will probably ask further questions, but so these charts are important, and I'm looking for your sources. And what we do at OHS is that we go back to sources that are, just to confirm. So all of this, where you like footnotes where you have your information, you know, sources for Medicare and Medicaid, you know, from CMS, public use file, all aid. Can you send us links? I mean, so, and we can talk about this
Yes.
later. There will probably be a list of late file exhibits by the time we're at the end of the hearing that OHS will want to, so on our own to look at, to confirm any kind of numbers. So one of the things, and perhaps on the next break, you can talk about it with the attorney. I mean, one of the things we'll be looking for is links to this information. I think on the other slide too, you had, you know, other sources. And, you know, for us, we just don't want to, you know, for us, if you want us to have the information, you know, we're going to probably need something more specific than some of the footnotes you've sent. So I think some of these documents are hundreds, if not thousands of pages. So if you could kind of send us a link, but talk about that on the break and we'll address this again later, okay?
Yes. We can definitely do that. And they almost all of the data links specifically to one source, that CMS public use files, but we will get you that link. And
yeah, and I think we're gonna need like specific page. I don't, you know, I haven't gone there, but like if it's a 1,000-page document, you're gonna want to refer us to what, you know, what you're specifically referring to, okay?
So surprisingly, this is one instance where the government has done a good job, and it's an Excel file that's manageable by state, and so that Brian and Orman are not going to fall out of the chair. It really is user friendly, surprisingly, but it is user friendly. But I'll get that data to you and the link to get to it. If we look at slide 4, same data source, CMS data, we're still talking about Medicare fee-for-service beneficiaries. Again, Medicare fee-for-service beneficiaries are the majority users of IRF, about 60% nationally. This is 2019 data. Connecticut continues to rank low in terms of the number of IRF discharges per 1,000. You're at 5, remaining at that level. You see other states around you. Rhode Island, for example, is 41. As I mentioned earlier, they have approved their review board a total of 100 beds to try to close that gap in care they're seeing there. Still, Connecticut is #1 nationally in terms of SNF. So you have the highest discharges in SNF in the nation and among the lowest in IRF. So we see that disproportionate in terms of discharge status, and we have the physicians saying they see it boots on the ground. So I'm looking at the data, and we've got the physicians who are talking about it. If you look at the next slide, the interveners have said that we do not need to use national data when we talk about Connecticut, that essentially Encompass or I just really don't understand what's going on in Connecticut. What you see in front of you now refutes that by looking at the general acute care discharges, again from Medicare, and using that as a benchmark. So when you see this slide, to make sure we're all on the same page, what it shows us is that in Connecticut, your residents are admitted to general acute care hospitals similar to the national average. So there's nothing unique about Connecticut that we're seeing here that explains why IRF is so low, and SNF is so high in terms of utilization, because for general acute care, Connecticut is consistent with the state average. So 296 admissions per 1,000 Medicare beneficiaries occurred in 2018 for Connecticut residents. That compares to 266 national average. What you see in the third column is Connecticut is 111% of the national average, or pretty commensurate with what's happening on the general acute care. So you have enough beds, the data is showing you have enough beds on the general acute care side that patients in need of general acute care services can get that care and are getting and receiving that care consistent with the national average. Where things go awry, if you will, from a data perspective and are disproportionate is on inpatient rehab facility. You see that instead of similar to the national average, IRF is 45% of the national average. So Connecticut is very different in terms of what's happening when patients are discharged to IRF compared to when they are seeking general acute care services. Likewise, skilled nursing is disproportionate to the national average, but the other way, 148.4%. So the national average is 64 per thousand discharges to SNF. For Connecticut, it's 95. Sydney, go to the next page, please. Okay, sorry. And that the same is occurring in 2019. The inpatient utilization did not change. Skilled nursing did not change in terms of the percent. So what we're seeing is an outlier. And that's why Dr. Charbonneau mentioned, and I'm seeing and know that there is a gap in care, and that what is happening from a data perspective and the physician's perspective is that IRF level that is so low is disproportionate, and patients are not going to IRF as needed or expected. Instead, they're going to skilled nursing facility disproportionately. The next slide, I'm shifting gears a little bit. That was Connecticut as a whole. Now I want to talk about Western Connecticut. What you see in front of you is the defined service area for the proposed project. And in the pre-file testimony, I described it as Western Connecticut. It is a 52 zip code area that's indicated on the map by that kind of aqua or blue color. It is in Fairfield, Litchfield, and a small portion of New Haven counties. In just a minute, I'm going to talk about the counties themselves and the utilization. That's because I cannot get Medicare data at the zip code level. So my proxy will be the counties. But to be very clear, when I get to the bed need methodology, this service area, these 52 zip codes, those are the basis, and that population is the basis for the bed need. So I'm going to intentionally kind of have to shift, and I'll try to make sure you know what's zip code and what's county. So that's our service area zip code. The next slide uses Fairfield and Litchfield counties as reasonable proxies for Western Connecticut. Again, I don't have it at the zip code level. And because I want to be transparent, and because we're going to share all the data sources with you, and they are sourced on the table, that's why I have to rely on the county level. So this is the same type analysis. Whereas Exhibit B was state level, this is county level. And what you see is the same phenomenon. In terms of the very first line, the two Western Connecticut zip codes are residents in those zip codes in those counties are utilizing general acute care services consistent with the levels at the national. So 285 discharges per thousand to general acute care hospitals from Fairfield County is similar to the 266 national. That's the 107.1% calculation. Litchfield is 104. Go to the next page for a second. It may
I have
be
a question.
easier
Can we
to-
just, I just have a quick, so can we go back to that last chart? So in these charts, where would someone like Danbury Hospital or other hospitals that do like a rehab, is that considered part of your IRF? Or is if it's done in a hospital, if rehab's in a hospital, it's not included? Where would that show in this chart?
Now, that's a great question. It would show in the chart for Fairfield and Litchfield County residents that use Danbury Hospital, IRF. They're included in that number. The IRF number. The IRF number. So let me say it this way to make sure. We're looking at where patients go. and I'm just looking at IRF, and it does include hospital-based inpatient rehab facilities. They're called distinct part units, and Danbury Hospital has one. They're, to my understanding, licensed for 14 beds. So when they treat a patient in that IRF unit, all of the data you've seen here, they are included. That's where the patients are going, just like if a patient goes to Stanford or Yale New Haven or Mount Sinai, if they're leaving their county and going anywhere, even if they went into New York for care, we know where the resident lives, and that's the basis for this number. So I'm not hospital specific, I'm resident specific. Does that answer your question?
Okay, I just wanted to know where those who got these, the rehabilitation in a hospital, where they would be counted. So it's under the IRF.
Yes, yes. That was probably too long an answer, but yes. And as Dr. Charbonneau mentioned and said, I would talk about the outlier is the IRF. Western Connecticut residents, the benchmark is that they're using general acute care consistent with the national average. There is no reason that you would not expect IRF to be commensurate with that national average. Instead, it's significantly below in terms of a percentage of the rate per thousand beneficiaries. And skilled nursing, consistent with what we saw at the state level, is significantly higher. The next slide shows this graphically. And I know we had a break and we had technical difficulties, but if you remember on Exhibit B, I had a line that was the national average. Here, I probably should have put a dotted line at the maybe 105% across, because that is the benchmark that we consider here. That's your general acute care utilization for Western Connecticut. And if you think of it that way, you see that Fairfield County has a significantly lower SNF utilization. That's the 63.6%. Litchfield has even lower at 36.4%. And if you imagine that about 100% line, you see SNF is disproportionately higher for both Fairfield and Litchfield. Slide 4 is updated data for 2019. I'm not going to walk you through that unless you have questions, but we'll look at the next page, and it is a graphic illustration of what we just talked about, but updated for 2019. And you see that Fairfield is the same with the 63.6%, meaning that Western Connecticut residents in Fairfield County are using SNF much lower than the national average, while they're using general acute care services about the same. It has dropped in terms of skilled nursing usage in Litchfield County down to 27.3%. So again, this is the data that we are relying on to understand there's a gap in care, and SNF is disproportionately being used in lieu of IRF. What's in front of you now is a graphic to show that I just looked at 2018, I just looked at 2019. This just gives you a longitudinal look from 2007 to 2019 to know that this gap in care has existed for many years. That despite your population aging in place, Fairfield County and Litchfield County are low utilization compared to the national average and compared to what I use as the national benchmark, which is a 75th percentile. So this is just a graphic illustration showing that. And again, all of this is the CMS data.
Okay, and what's the reason for, what do you have any data? I mean, so I look at, 2000, it starts going down 2012, 2013, so Connecticut is down from the national average. Are you saying that's because there aren't enough beds?
Yes, and thank you. I should have drawn that conclusion for you, but that is exactly the point, is that there are not beds that are locally available and accessible for this population.
Okay,
And in fact, the interveners, I'm sorry.
I didn't mean, but so you're saying there are not enough beds, and that's all based on the Medicare data?
There are not enough, yes, there are not enough beds. And so what is happening is that patients are substituting inappropriately less intensive care that is skilled nursing instead of going to inpatient rehab. So that's the data that's showing me there's not enough beds. Patients don't have the options locally. We know that Danbury Hospital is at, I think, 85% occupancy in FY20, 94% in FY19. So they're full and they're the only game in town. So patients don't have the number of beds needed to be discharged to IRF. The physicians have written letters, as has the Brain Injury Association, that describe that and talk about that the patients are unable to get IRF care when needed, and then the problems resulting because they are using SNF in lieu of that. Does that answer your question? That was a long answer.
Yeah, I think there'll be some follow-up questions later, but I just kind of wanted to see where what these numbers are based on. So, but yeah, go ahead.
Okay, and again, to be clear for the record, they are Medicare based. Medicare is about 60% nationally of the population served, but it is representative in terms of what's happening in the market. Okay. The gap in care that I've talked about, and the fact that there are too few beds, so patients are utilizing skilled nursing facilities instead of inpatient rehab facilities, will exacerbate and worsen, I believe, if you do not approve this, if OHS does not approve this project. The reason I say that is the elderly population is the largest user. What is happening in the service area, this is not county, this is the 52 zip code service area. The population 65 and over, as you can see, is increasing by 15% between 2020 and 2025. That means by 2025, almost 1 in 4 residents will be 65 and over. So that gap in care, that disproportionate use of SNF to IRF will worsen because you have too few beds currently and you have an aging population, and that's the primary user of the service. In front of you now is the bed need analysis. A couple of comments before I walk through the detail. This is a population-based analysis. I told you early on that I had a twofold charge from Encompass. One is to confirm that there was beds needed in Western Connecticut, and then to quantify the beds needed. And when you have a service that is currently not being utilized because there are too few beds, it is not appropriate to look at historical utilization as a measure of need, because that historical utilization is going to be understated. So what I have done here is a population-based methodology that relies on publicly available data, and I have proposed or used a target rate of 13 per 1,000 discharges. So this is quantification of beds needed for the 52 zip code area. This methodology does differ fundamentally from OHS. And the question before OHS is really simple. Do you believe the status quo is acceptable, or do you not? The status quo, if you believe it's acceptable, then you look at the need based on historical use and just factor in population. What I am proposing that you do instead is recognize a gap in care and try to quantify how many beds are needed to fill that gap in care. This methodology, or something very similar, has been accepted in Rhode Island, Illinois, Georgia, Florida, Kentucky, and South Carolina. it does differ intentionally from OHS's. So I do want to be very clear about that. Line by line, was that, I assume you would like me to walk through that, OHS would. Line by line is that the first line you see is the Medicare beneficiaries projected for 2025. So in that, if we think back to that map and that blue area on the map, the defined service area, 111,256 beneficiaries are projected. The data that I have available, that's publicly available, is from Medicare fee-for-service. So I needed to take the total 65 plus population and just look at Medicare fee-for-service before I applied that Medicare fee-for-service target discharge rate. So that's why the 56.8, which was your calendar year 2018 Medicare fee-for-service beneficiary number, results in how many Medicare fee-for-service beneficiaries are in that 52 zip code area. That's your 63,193. From there, it's math. It's 13 per 1,000 discharges as the target rate so that you can close that gap in care, have enough available beds that patients are getting care close to home. If you multiply the 13 times the fee-for-service beneficiaries, you have a projected 822, line 5, Medicare fee-for-service admissions. But we know that Medicare fee-for-service admissions are not all. We know that there are Medicare Advantage, there's Medicaid, there's commercially insured. And so we've got to take that 822 and look at the rest of the population or patients that will be served so that all payers are covered, if you will. That is the 1,393 number. From there, again, math, what is the Connecticut average length of stay in fiscal year 19 was the 12.8. That gives you on line 9 your total rehab days. You would need 49 beds if that's the case, but your state health plan uses an 80% rehab occupancy rate. So I applied that to the 49 beds to get a gross bed need of 62 on line 12. I gave effect to the 14 existing beds at Danbury Hospital, and the net bed need for that 52 zip code area, therefore, is 48 beds. I don't know if you have any questions or you want me to keep going.
Yeah, I think we'll save some, I think there probably gonna be quite a few questions on the methodology, so we'll just wait until till later, but you can go ahead.
Okay. In thinking about the state health plan, I would like to make 2 comments. You know, I've recognized and appreciate the state health plans and respect the state health plans methodology. Also, when you look at the state health plan, I think it's the next page. I think it's 27, page 27 of the 2012 state health plan. I'm probably totally messing that up. But it does, the state health plan talks about 2 things. And it talks about not just looking at the quantitative approach, but considering the innovation or changes in the delivery of healthcare that may be needed, which is what you heard Dr. Charbonneau talk about, and the ability to take care of the patients. I will talk about the complementary services Encompass proposes in just a minute. Dr. Charbonneau talked about the resources to treat the patients as well. So that's one consideration I would ask OHS to consider. And then the other in your state health plan is that quality or patient concerns is also another factor that should be considered. With that, I'll turn to Exhibit F. Encompass, Dr. Charbonneau is the expert on this, obviously. Encompass provides a wide range of services. And in terms of the data, the point I'll make in a minute and why I want to start with this is that I believe, and the data shows, that Encompass's services will complement the existing provider. if you look at Danbury Hospital, let me tell you what's in front of you first, I'm sorry. These are the conditions that are served in inpatient rehab facilities. This is the first instance in which you see specific hospitals in Connecticut mentioned, and that's across the top. You see, for example, Danbury Hospital, Stanford Hospital. What the numbers and the percent represent the Medicare fee-for-service patients. Again, that's our public data. What type of patients have been served at each hospital? The first column percentage is the national average. And then the numbers and percent for each hospital again is what does their patient array look like? In Connecticut, your hospitals are primarily focused on stroke. Danbury Hospital is focused primarily on stroke and then secondarily spinal cord disease. Encompass will complement those services by not just caring for stroke or spinal cord, but a wide array of services. In fact, the updated data that Danbury provided, I believe, shows an even greater focus on stroke, but we'll hear about that from them, I'm sure, later. So my point in showing this is that Encompass believes that they will complement the services, not compete with Danbury, and that because of the aging population and the size of the population and so few beds, that there is enough patients for both providers. There's more than enough likely. If you look at the next page, we think about IRF and discharges, and we think about where the patients come from. So the purpose of this slide is to look at the vast array of hospitals in the 52 zip code area or adjacent to the 52 zip code area, and think about the number of patients that are not only going to Danbury or a Nuvance hospital, but are going to other hospitals as well. For example, to Waterbury Hospital. So you have residents who are seeking care at multiple hospitals in and around Western Connecticut. Those are the patients that Encompass seeks to serve. To be very clear, Encompass and my projections are not based on redirecting or shifting Danbury Hospital's patients. Danbury Hospital serves predominantly its own patients and patients from Nuvance Health System. I view that as a closed system, if you will. Waterbury Hospital, for example, if they have a patient in need, Encompass would accept that patient and not prioritize any systems patient over the other. So I do think that's important to think about in terms of a freestanding inpatient rehab provider that would be located in this Western Connecticut area.
So each one of these hospitals, each one of these yellow dots is also an IRF.
No, thank you for asking that. That tells me I did an awful job of explaining it. The yellow dot are general acute care hospitals.
Mm-hmm.
And those yellow dots are where patients are being discharged and would need inpatient rehab facilities.
Okay, so I know Danbury Hospital, as you just said, it is considered an IRF, correct?
Yes, and it's an IRF within Danbury Hospital. So here I'm just showing what general acute care provider.
Okay.
Like Waterbury, does that make sense? Waterbury
Well, I'm just
Hospital.
wondering, so all these these hospitals, so like how many of these other hospitals, like Danbury Hospital, has the IRF services?
That's a good question. Within the service area, there are none. But yeah, within the service area, there are none. Outside of the service area, statewide, there's a total of 6. So if you look at St. Vincent's, Stanford, those, and Yale New Haven on the shoreline, those 3 general acute care hospitals also have inpatient rehab facilities. I believe that I have in the CON and can find it if it will help you, a map that shows where the IRFs are located.
Okay, I'm sure I went through it and I'll look again. If you say it's there, I'll find it.
Okay. And I will find that and get that to you. So the yellow dot are general acute care hospitals that are in need of an inpatient rehab provider to which they can refer patients. Danbury has talked very specifically about the importance of their continuity of care for their patients. And so again, what Encompass brings to the table is the ability to accept patients from any system without prioritizing one system or the other. I'll have to look for that map and I'll get that to you. But just big picture, outside of the 52, go back one more time, outside of the 52 zip code area, you have a few IRFs on the shoreline, on that I-95 corridor. You have an IRF, you have 2 IRFs in Hartford, and then you have one, Lawrence Memorial is in the far eastern Connecticut, if that helps you. Okay.
Bates page 51. It's just Attorney Yondo, if the map on Bates page 51 of the CON application is a map that shows where all of the hospital-based and IRFs are in the state.
And thinking about the number of general acute care hospitals and the number of patients from each general acute care hospital, which is the purpose of the prior slide, I use that, and now I'm turning to this data to show that there is sufficient volume and sufficient discharges from all of those area hospitals, general acute care hospitals, so that when Encompass comes in and educates the market, begins talking to physicians, begins talking to case managers, that, for lack of a better phrase, rising tide lifts all boats. This is data that shows 4 different areas. You see those on the left. Philadelphia is the second one. Their average IRF occupancy before Encompass opened a new facility. And then you see 3 years post Encompass coming in the market with a new facility and what happened. And in each instance, the occupancy or the average occupancy for existing providers remained the same or increased. And that is because, going back to Dr. Charbonneau and to the physician letters that we have in the CON, when patients are going to SNF instead of IRF, and there is available bed capacity, because there's too few beds now, then patients begin going to IRF in proportion to what we expect. And as Encompass is educating the market, it's not just Encompass that will see increased volume. As shown here, other providers do as well. There is a CON requirement about, you don't call it adverse impact, but you call it unnecessary duplication of services. What this shows with the data and the facts is that Encompass, when it opens this hospital, will not be an unnecessary duplication of service. That instead it will bring accessible services that are high quality to the market. The next page, I'm shifting gears. This is skilled nursing facilities. So on the one hand, what I just showed you was that when Encompass comes in and educates the market, they identify patients in need of rehab that have not previously received it. And a number of those patients, more than in the past, are going to inpatient rehab facilities. So they're closing that gap in care, and it benefits existing inpatient rehab providers. What also happens when Encompass has gone into markets, and these are in CON states, is that the skilled nursing facilities have benefited as well, because Encompass will go in and identify a pool of patients that need rehab services. Not all of those patients are able to withstand 3 hours of therapy a day, which is one of the distinctions between skilled nursing and inpatient rehab, for example. So what you see here is when Encompass went into the market in Middletown in Delaware, you see the skilled nursing facilities occupancy before and after. I'm sorry, the first year and the following years, and you see that the occupancy continued either the same or increased almost in every case. And the same thing with the next slide. This is in Georgia. Encompass opened a new 50-bed hospital. The skilled nursing facilities occupancy increased the same or stayed relatively flat. There was not a detrimental impact on skilled nursing facilities. The same thing is true on the next slide, which is Virginia. It's another CON state. When Encompass came in and opened a new hospital, you see that the occupancy either remained the same or in many instances increased. The point of all that is that there are enough patients for the skilled nursing and for inpatient rehab providers, Danbury and Encompass together. The last section is shifting gears a little bit. In Connecticut, as in many states, one of the criteria is also cost-effective care. And I want to talk about the cost effectiveness of care in two buckets. The first one is IRF, inpatient rehab facility, and then the other will be comparing IRF to SNF. What you see in front of you is essentially showing that Encompass has lower cost and lower payment per discharge compared to other IRFs. So I'm apples to apples. This is IRF to IRF. And if we want to, this is national data. So before I get beat up on that, let me talk about Connecticut data. Because in Connecticut, if we look at the cost effectiveness of care, Encompass's proposed fiscal year 24 charges are $3,700 lower per patient or per discharge than Danbury Hospital current. So that's one reason that Encompass, when I talk about cost-effective care, I have the data to support that. And that information was in the rebuttal response filed last night. Go to the next one. So when we look at IRF, which is what we just did, Encompass has cost-effective care. If I now shift and talk about Encompass versus skilled nursing facility, an easy and incorrect way to compare costs between Encompass IRF and skilled nursing would be to say, well, skilled nursing is cheaper. The cost per day is cheaper, the reimbursement is cheaper, just like home health. It's cheaper, it costs less. Well, you're right, because it's less intensive services provided at skilled nursing, home health, for example, compared to rehab. So what you see here is illustrative of resource intensiveness and as identified by Medicare and what they're willing to pay. For example, inpatient rehab, $1,689 per day is the Medicare reimbursement. Skilled nursing is the $595. These are actual costs. And then home health is $38. So my point here is, if we just say, well, it's cheaper to go to skilled nursing than inpatient rehab, you're right, but we can't stop there because there are peer-reviewed journal articles, two of which I referenced in my pre-filed testimony, that talks about the downstream medical costs and the downstream morbidity. If you turn to the next slide, for example, what you see is that this is one example, it was from a Texas health system, that you have to consider the readmission rate and therefore the full cost of care for patients who are inappropriately placed in SNF. Without walking through all the detail, and I can if you'd like me to, the point of this slide is skilled nursing may be cheaper, and it is cheaper, even though the patients are staying there longer. It's cheaper because there's less resources. The patients aren't receiving as many intensive services. We have to consider the readmission. So here what happened is for cardiac valve, patients did change from going to IRF to SNF. That's your blue bars. So the facility or the system thought they would save money by shifting from IRF to SNF. And then what you see is the second set of light green is the system did save on their first admission. When the patient left their hospital and went to skilled nursing rather than IRF, it was cheaper. But their third column is those patients were readmitted because they did not receive the appropriate level of care. And so because of that, the cost of care has to be considered for that readmission. And so when in the fourth set of columns, what you see is that the total episode of care is actually greater when you try to get the cheaper cost on the front end for the patients that are more appropriately placed in IRF. And with that, I'm through with my exhibits, and I'm sure there will be questions.
I think you're muted, Attorney Yondo.
Yeah, okay, there we go. Thank you. I have a few, and then I think that I'm going to let Attorney Fusco see if she has any more direct she wants to follow up with any of her witnesses, and then we're going to take a brief break, and then I'll come back and we're going to allow cross-examination. I'm going to see what witnesses, I'm going to ask the intervener, and I'm sure of Ms. Chafin. I imagine that there are some questions, and I'm going to want it like limited to 19A, 639, and certainly any kind of questions that might bring any of your direct testimony, that would help me weigh, how whether or not how relevant and how much weight I should give the data. My concern is, I want to focus, the focus on Connecticut. And I know a lot of your stuff is, based on national statistics and Medicare. And I appreciate that. And I'm going to certainly take that, and I'm going to give that some serious consideration. What I'm hoping, maybe from the OHS staff and maybe what we're going to hear from the intervener, or maybe some questions to see, the effect, of Connecticut, versus, the other states. So where would you get your patients from? Are they referrals from hospitals?
Yes, that's a really good question. The 90%, so 9 out of 10 patients come from general acute care hospitals. They are admitted to Encompass directly from general acute care hospitals. And if you look at the map, that was the yellow dots. That's why I put all those yellow dots. There are a number of hospitals that have a number of patients in need of inpatient rehab services. In the application, when I looked at where the patients would come from, see on page 711, 711, then that gives you an idea of the number of hospitals that would provide discharges for Encompass and the order of magnitude. For example, Danbury Hospital had over 3,000 discharges that I would identify and Encompass would identify as rehab appropriate. And that's only Medicare fee for service. So when we think about their total patients, Danbury Hospital had over 4,500 patients that we identify as rehab appropriate. And out of that, 200, I believe, last year received inpatient rehab facility services. So to answer your question, patients would come from, we expect, Danbury Hospital, as well as the other hospitals in the area. Dr. Bueno will talk this afternoon, and he's from Waterbury, and he will talk about the need for additional inpatient rehab services. So that's just illustrative of the need and where patients are coming from. So general acute care hospitals are the predominant source of their admissions.
Attorney Fusco, do you have other witnesses you're putting on in your direct?
No, Attorney Chafin's our last witness.
Okay.
Oh, sorry, Attorney Chafin, I've elevated her. Sorry.
Okay, okay. All right, no, she just made, okay, so 90% from other, and who, I know, you said there are other witnesses available if OHS wants to talk to them. Who was it that you were making available?
We do have, I mean, I guess it just depends factually. I mean, we have someone who works with Ms. Chafin who worked on the financials. If there are questions about the financials, we have an individual who could talk about facility design, who's actually been involved in the design and planning of the facility. We have development folks who would speak to, I know Mr. Tour mentioned that he was not involved in the initial planning stages for this project. The individual whose position he took was retired. So, you know, if there were questions historically about the development of the project, there's development staff that could answer. I don't think I'm missing anyone. No.
Okay, all right. So I have a few more questions of Ms. Chafin, and then so 90%, you're expecting 90% of the patients to come referrals from hospitals. So it would be Danbury, and I believe there's a list in the pre-file about there was a certain percentage of patients you believe will be from Danbury. Is that correct?
Yes, that's correct. With the caveat that it really is a rough estimate. And I think I may have used the phrase almost a mathematical exercise, but that is correct.
Yeah, and do you recall what was the percentage that was in that chart?
In the chart, it was 20.9% in terms of, and that's of the 90%, not to try to be confusing, but because 90% of patients will come from hospitals, of the hospital generated patients, Danbury's 20.9.
Okay,
Overall,
okay, and out of that 90%, what other hospitals? And I know there's a chart, but just if you could sort of just repeat that for me. I think was Sharon one of them? Was that the second?
Sharon was one, and it was only 8 patients from Sharon out of
what was the percentage?
1.4%.
1.4. What was the second? I think you had Danbury as number 1. What was the second highest percentage from a hospital?
Norwalk Hospital, and
Norwalk.
I realized they're Nuvance Hospital. They closed their inpatient rehab facility, if I'm not mistaken. Their percent is 13.2. So
13.
yeah, so for order of magnitude, that'd be 74 referrals out of over 1,625 rehab appropriate patients that are discharged from that hospital. Medicare only, right? So that number is going to be probably more like 2,000. So just to answer your question fully, the 13.2% may sound high, but it's 74 patients out of almost 2,000 patients that Encompass believes are candidates for inpatient rehab facility services, if that helps.
Okay, well, it's okay. So it's like third, so it's a third. I mean, it's a third of the 90%, correct?
No, it was 13%.
Plus the 20, the Nuance hospitals. I guess it's Nuvance.
That would combine their 33%. That's correct.
So that's 33% of the 90%. Is that right?
That's correct. Yes.
Okay. All right. I just wanted to make sure I'm okay. And these hospitals, and I know you have a list of other hospitals. Have you had discussions with those hospitals about the referrals?
I have not. I know that Encompass has spoken with Danbury Hospital in the past, and I know that Encompass has spoken with physicians in the community that will talk today or have written letters, but I have not spoken to any of the hospitals.
Okay. And do you know who in Encompass would have talked to the hospitals?
I do. It would have been Bill Heath. He is their business development person. I believe I'm telling you right. Well. No, that's true. And then, that's true. And then Mary Lynn Swartz has also spoken with community physicians that are in support of the proposed project. She is she's a nurse by training and a former hospital CEO, and had some outreach to specific physicians that have expressed support for the project. But she did not, I speak with Danbury Hospital representatives, I do not believe, but the physicians who ultimately refer the patients, that's who she talked to. And I guess that's one thing, if I can try to clarify, is that, and this is a PAT tour issue, perhaps even better, is that the patients are being discharged from Danbury Hospital. It's the physicians and case managers that are taking care of those patients who are looking at where they need to go and referring those patients. So the physician is key, which is why Mary Lynn Swartz talked to community physicians and why there are several community physician letters in the support in the application. So they're discharged from the hospital, but the physician is going to be key in referring or dictating or just prescribing where they go for post-acute care services, if that helps.
Okay, no, thank you. Attorney Fusco, do you have anything else with your case in chief?
Just wanted. I just want to if I could just redirect very briefly, just to clarify something.
Well, I mean, this is all part of your direct, so.
Absolutely, just because I think it will help clarify this chart that we're talking about. Ms. Chapin, can you explain to me how you arrive at the number of Medicare fee-for-service rehab appropriate discharges for each hospital?
Yes.
The data you look at.
Right. This chart, and I'm sorry we don't have it to show, although I think we do, which may be helpful. I will pull it up. See, on page 711 has two sides to it. It has, to your question, Attorney Yondo, is that what is the estimated percent of patients by hospital? That's on the left side, those numbers. And then on the right side of this chart is what I wanted to give was perspective. You know, I was quoting the total number of patients. Again, using that publicly available Medicare fee-for-service data, I know, for example, that Danbury had 3,013 rehab appropriate discharges in calendar year 19. And a couple of points with that. One is that is only a portion of patients that I expect and Encompass expects are rehab appropriate, eligible, and would likely benefit from rehab. And the rehab appropriate terminology is that the total discharges from a hospital, when you think about patients that are being discharged, they're not all going to go to rehab. They're not all appropriate for rehab. We can easily eliminate, I'm not clinical, but we can easily eliminate OB, typically psychiatric as well. So we will, and like cardiac cath lab. So there are certain patients that Encompass, based on the data that Dr. Charbonneau talked about and years of experience, they know who is likely going to be in need of and benefit from IRF. That is what the far right two columns show, is that if we look at Medicare fee-for-service only, which is a portion of patients, and we whittle that down to rehab appropriate, you see a minimum number of patients that we expect are eligible or appropriate for rehab. Does that answer your question? Okay.
And then in comparison, sticking with Danbury Hospital as an example, what percentage, we focused on the fact that they would account for 20.9% of our referrals, but what percentage of their rehab appropriate discharges would we expect to come to us?
This page 711 and what's in front of you shows 3.9% of Danbury Hospital patients we expect would go to Encompass Health, but My caveat, and that's why I mentioned that this is only Medicare fee for service. If you look at Danbury Hospital, they treated in their rehab unit, 64% of their patients were ages 65 plus, essentially Medicare. So I've got to take that 3,013 and bump it up to represent apples to apples in this chart, to show you total rehab appropriate patients, which would be about 4,700. So that's a long answer to say 2.5% of Danbury Hospital's over 4,700 rehab appropriate patients in 2019 would be expected or estimated to go to Encompass Danbury. So a very small percentage of the total pie.
And so in follow-up, so, let's just focus on the Medicare fee-for-service data that we have here in front of us. If Danbury Hospital were to refer Encompass 117 of those rehab eligible discharges, how many patients approximately, how many rehab eligible discharges does that leave them, with which to fill their own unit and to refer elsewhere?
Over 4,000 if you consider all the payers, which would be appropriate, a significant number. And that's why previously the slide that I showed, the data and the reality and the history of Encompass going into a market has been that the existing providers do see an increased volume. And if you step back and think about it for just a minute, from a health planning perspective and a business perspective, it would be nonsensical to think that Encompass would come in and try to run Danbury's IRF out of business when they will provide care for patients at Danbury Hospital. I see that they will have a positive relationship, which they do in other markets with Danbury Hospital.
And so just to clarify, those 117 patients that we would anticipate Danbury would refer, those are not patients that are already getting care or would be getting care in Danbury's IRF, correct? Those are just general acute care discharges from the hospital that are IRF eligible, meaning we're not saying we're going to shift 117 of their IRF patients to our inpatient rehabilitation facility, correct?
That's correct. I would expect Danbury to continue caring for their patient population. The patients that are currently not receiving IRF that need it would get it. That's why we talk about the high number that go to skilled nursing instead, or go to home health or just don't get it at all. There is not a shifting of patients anywhere in my analysis, nor do I expect it in reality. That's why I keep going back to rising tide lifts all boats. When you have someone come in and educate the market, when you have that gap in care, when you have the disproportionate skilled nursing utilization high and the disproportionately low IRF utilization, there are more than enough patients to go around. This does not assume any shifting or any adverse impact on Danbury Hospital.
Thank you. I don't have any more questions, and that concludes our presentation, our direct evidence. Thank you very much.
Okay, great. So nothing of the other witnesses either then?
No.
Okay, so what we're going to do is we're going to take a lunch break. We're going to break until what is it, about 12:30. We're going to break until 1:10. We'll make it 1:15. We're going to break until 1:15. When we come back, we're going to start with a cross-examination by the intervener of Ms. Chafin. And which counsel will be doing cross-examination? Okay, thank you. Thank you. Okay, so actually, let's make it 1:10. 1:10 we'll come back, and by the time we get started. So 1:10, we will be back and then start with cross-examination. All right, so we'll go on break. Remember to turn off your audio and your video too, and we'll be back at 1:10. Is Attorney Fusco on?
I am just trying to get my video on. Let's see.
I just had to
Okay,
change
we're
my
here.
gallery, had to see you. I
Yes, I'm
only see
here.
some.
Yeah.
Okay. All right, Ms. Chapin, remember you're still under oath,
Yes.
all right? Attorney Tucci? All right, I'm pronouncing that right, Tucci?
You got it exactly right, Hearing Officer Yondo. Thank you.
Okay, all right.
May I proceed?
Yeah, you may proceed. I mean, keep it, you know, what I'm interested in is, the elements under 19A 639. And, as far as any kind of information during the direct that needs more expansion, or if you believe that there's any type of anything that would help, go to the how I should weigh a piece of evidence that was offered.
All right, thank you very much. Good afternoon, Ms. Chapin. How are you?
Good. How about you?
I'm just fine. Can you hear me all right?
It's not great, but it's okay.
Okay, I just heard recording stop. Oh, all right. I think we're okay. I heard it's in progress now.
All right, I'll proceed. Just for the record, this is Ted Tucci, counsel for the intervener Danbury Hospital. Ms. Chapin, you have, am I correct in understanding that you took principal responsibility for the creation and submission of the written materials on behalf of Encompass Health, including the CON application and the responses to the completeness questions? Would that be fair?
That's correct, yes.
And as I understand from your direct testimony, the business model that Encompass is presenting in its CON is one where the expectation is that the volume for the new facility that is being proposed in Danbury, approximately 90% of the patients who will be expected to be admitted into that facility will be as a result of referrals coming out of acute care general hospitals in the state of Connecticut, correct?
That's correct. So approximately 90% would be discharged from general acute care hospital. Again, the physician is driving that, but they are going from a general acute care hospital into Encompass.
All right, and if you could go to your 2020 completeness question submission, in particular question, the response to question number 10, please.
Can you repeat?
Yes, the 2020 completeness question response. And specifically, I'm directing your attention to question number 10.
Can you give me a page number, please? Bait stamp.
1-4. Are you looking, Attorney Tucci, at the first completeness response, the one from October 16th, 2020?
That's correct. Page 8, question 10.
Let's see, it's 492.
Page 8 of the, let me just make sure I'm on the October 16, 2020 submission.
Yes, it's base page 000492.
Okay. 493.
2.
Okay.
So in this completeness question, OHS asked Encompass which hospitals Encompass was establishing transfer agreements with. And the response that you provided on behalf of Encompass was, quote, Encompass typically executes a transfer agreement with one or more of the closest hospitals, correct?
That is what it says, yes.
And we know from your earlier testimony that with respect to the acute care hospitals that are in the 52 zip code service area that you've identified, that the acute care hospitals within that service area are Danbury Hospital, New Milford Hospital, Sharon Hospital, and Charlotte Hungerford Hospital, correct?
If you can point me to my exhibit to make sure we're looking at the same exhibit.
Sure. Well, you feel free to pull up your map on the screen if you'd like the hearing officer to see it. The service area that you've identified.
I just want to make sure you're looking at my exhibit F, page 2.
Sure. Can you put that up on the screen so that the hearing officer can see it?
That's it.
All right, so I had that information correct, don't I? That we're talking about 4 hospitals that are in the geographic service area that your proposal has identified?
In terms of hospitals within the geographic area, yes, there are 4 general acute care hospitals. That does not equate to the hospitals that will refer patients to Encompass Danbury, as long as we're clear on that.
I'm very clear on that. What I'm asking you, ma'am, is if you agree with me that in the geographic service area you identified, which is the service area where you believe there is a gap in care, am I correct that there are in Connecticut 4 acute care hospitals? Sharon, Charlotte Hungerford, Danbury Hospital, New Milford, and Danbury Hospital. So that's a fact. That's a fact, right?
That's correct. In Connecticut.
Yeah.
And that are contiguous. So I would agree with that.
Yes. And it's also a fact that as of the last written materials that Encompass has submitted to OHS, you have reported the existence of no transfer agreements with any of the hospitals in that service area, correct?
Well, that's correct. The CON application is not yet approved, so I would not expect Encompass to have established a transfer agreement at this point in the process.
And in fact, in your response to the completeness question number 10 that we're looking at on page 492, I believe you reported to OHS that Encompass's typical approach is to, quote, begin discussions regarding transfer agreements while the new hospital is being built. Is that right?
That's correct. And that is typically what they do, and they have been successful in establishing those transfer agreements.
So the plan that's being proposed here is to get regulatory approval for a 40-bed hospital, start building it, and then see if you can fill it up, correct?
Say the last part. I'm sorry, I couldn't hear you. I'm having a hard time with the sound.
Just to get approval from the Office of Healthcare Strategy for a 40-bed hospital, start constructing it, and then see if you can get agreements in place to obtain 90% of your referrals from hospitals, correct?
I'm going to object to the form. That's not what a transfer agreement is, as OHS requests. This question deals with transfer agreements, which have to do with sending patients from the earth who are in need of acute care hospital services to the hospital for those services. A transfer agreement is not a referral agreement, so I object to the question.
Okay, hold on. Okay, so Attorney Tucci, can you reframe your question?
Very simple, and I won't belabor it, Hearing Officer Yondo. Ma'am, you will agree with me, will you not, that with respect to the establishment of any written transfer agreements with acute care hospitals in Connecticut, Encompass has not yet been able to accomplish that, correct?
That's correct, because the transfer agreement is for an inpatient from Encompass Danbury who needs general acute care services to be transferred to an existing general acute care hospital. So it would be the patients in the facility that they are transferring to another facility. So it doesn't make sense that they would have a transfer agreement in place now.
In addition to the 4 hospitals that are located in the geographic service area you've identified, the Encompass proposal also relies on the expectation of referrals of patients who are discharged from 10 other hospitals in the state of Connecticut, correct? And if it would help you, I'd direct you to your response to of January 8, 2021 to, I'll get you a page reference in a minute, to page 000524.
Yes, to answer your question, there are hospitals outside but in close proximity to the service area, or hospitals that are serving residents from the service area are included. So the hospitals listed here are serving patients from the Western Connecticut area. So as these patients are discharged from hospitals, we would expect if there are available IRF beds, those patients would go closer to home and receive that IRF care.
All right, and I believe you put this chart up on the screen earlier. Can you put it up again so that we can talk about it in a little more detail?
Yes.
All right, now looking at the 10 other hospitals outside the 52 zip code service area that you have identified as the primary service area for your proposed new facility, the chart shows that Encompass expects to get patient referrals from the following hospitals. In particular, I want to focus on the following 5 hospitals. Bristol Hospital, correct?
16 referrals, that is correct, out of their more than 500 rehab appropriate discharges. That's correct.
And according to your chart, you expect that Bristol Hospital will send approximately 2.8% of the 90% hospital referrals will emanate from Bristol Hospital discharges, correct?
Mathematically, that's correct. Again, that is based on patients that are currently going to Bristol Hospital from the service area.
Hospital, your projection is that it will be 11.8% of the total volume you're projecting for your hospital discharges, correct?
From Hartford Hospital, that is correct. Again, based on the patients and the residents from the geographic service area that are currently traveling to Hartford Hospital for services that are rehab appropriate. And when you factor in more than just Medicare fee for service, to give perspective, out of probably more than 5,000 rehab appropriate patients, 66 would be expected to be from Hartford Hospital, based on residents now that leave their area to go to Hartford Hospital for care.
From Hospital Central Connecticut, 1.1%, correct?
That's correct, which is 6 patients.
John Dempsey Hospital, 3.9%, and St. Francis Hospital, 9.0%, correct?
Correct. Again, 22 patients out of more than 900 for John Dempsey. And then, I'm sorry, the other one, that St. Francis is the other 51 out of close to 4,000 patients that reside.
Right now, I'd just like you to focus on percentages. I've read to you percentages, and you're very good at math, and correct me if my math is wrong, but of the 5 hospitals that I've read to you and the percentages that are in your chart, that's a little less than 30% of the total hospital discharge volume that you project will make up the patient census at this hospital that's being proposed to be built, correct? 28.6%.
I would have to add it, but that's the math, again, mathematically, that sounds correct.
Okay, and you would agree with me that the 5 hospitals that we've just focused on are clearly outside of the primary 52 zip code service area that you've identified where there's this gap in care, right?
The hospitals themselves are located outside of the service area. The residents they serve are within the service area. And that's why I would expect if there are sufficient numbers of inpatient rehab facility beds, and they are with a provider such as Encompass that is freestanding and is not going to prioritize one system over the other, that those patients could in fact receive care close to home through Encompass.
Our expectation is that 28.6% of the volume is going to come from patients who are discharged out of hospitals in central Connecticut. Is that correct?
Well, you're ignoring Waterbury Hospital, I guess, in that.
I've strictly asked you to focus on the hospitals that we can agree are located geographically in the central Connecticut area.
If you are ignoring Waterbury, then let me just do the math on the ones that you are selecting and ignoring the others to make sure I am following you.
Well, ma'am, I'm not ignoring anything. I'm asking you to focus on a geographic region in the state of Connecticut, which is in the central part of the state. You would agree with me that all the hospitals that I've identified are hospitals that are physically located in neither Fairfield County nor Litchfield County.
Okay, Attorney Tucci, I just, if she maybe, need to look at the map while she's talking. So I just want to give her the time. You're asking to do math. She probably has to look at the map for Connecticut about where these hospitals. So just give her time to pull together the answer.
Sure.
While she's looking, I mean, one of the questions I'm interested in, and certainly Attorney Chafin is much more, aware of what's in this information that she cites to, but does this information that's cited tell you that the patients that go to Hartford Hospital or St. Francis will specifically need rehab services, and that they live in the geographical area, so that the sources that are there, do those sources tell you that information?
Yes, and that's why I keep trying to be responsive to his question, that when you're talking about the hospital location, you have to instead focus on the patient's location. And you're exactly right. The estimated referrals are based on the patient's residence. And these are absolutely for patients who are, let's say they're involved in an accident. They end up going to Bristol Hospital in his example. And when they are discharged from Bristol Hospital, because they live in the service area, if Encompass Danbury were there and had available beds, we would expect the patient to be discharged to the IRF closer to their home, which would be Encompass Danbury.
And you got that information from the Medicare discharge data source?
That's correct in terms of their residence and in terms of their diagnosis, their DRG that caused them to get into that general acute care hospital. Yes.
Okay, I'm sorry, Attorney Tucci, I just added to clarify that for me. So if we could, so go ahead and re-ask your question.
Let's focus on the Bristol Hospital example, where you have estimated that 16 patients out of the 90% that will come from hospitals will come from people who are discharged after getting care at Bristol Hospital. The column that you've identified on the right-hand side of your chart is what you described as Medicare fee-for-service rehab appropriate discharges in calendar year 2019, correct?
That is correct.
And you say that in 2019, there were 495 patients discharged from Bristol Hospital who you described as being Medicare fee-for-service rehab appropriate, correct?
That's correct. And so it is a subset of their total patients that would be discharged that are rehab appropriate, because it is only Medicare fee-for-service. So it is more, I guess, appropriate to look at 825 discharges to have apples to apples. Because if you assume approximately 60% of the total rehab appropriate patients are Medicare fee-for-service, then all payers would be 825. So let me say it a different way. the total.
Ma'am, can you
I was
please?
still responding to your
No,
question.
Yeah, no, so, yeah, counsel,
Yeah, I'm
let
gonna
her finish her
object.
response, okay? I appreciate the questions and this is fair, but I do want her to finish her response. If she goes off, I'm going to be very, I want the cross-examination. I want to, hear it from Danbury, but I do want to allow her to finish her questions and I want to gather all the information.
Very good.
You can finish your answer.
Thank you. So that we're comparing apples to apples, the 495 represents only a subset of the rehab appropriate discharges. So if we assume 60% of the total rehab appropriate discharges at Bristol Hospital are Medicare fee-for-service, what that means is it's a bigger pool. It's 825 patients in total that Bristol Hospital saw in calendar year 19 that had that car accident, that need that intensive rehab care after they're discharged. So the 16 would be 16 patients out of a total potential pool of patients being discharged of 825. Because what you see in front of you is the left side is all patients, all payers on that chart, and the right side, for order of magnitude, was just Medicare fee-for-service, just a subset. So it was apples and oranges to some extent.
Okay, I do want to, Ms. Chafin, your attorney will have a chance for redirect. So so I want you to focus on the question, answer the question, and your attorney has a chance for redirect. So if she feels that she needs to ask you on any follow-up, she will, okay? Go ahead, Attorney Tucci.
Officer. So looking at your table 1 chart again, Ms. Chafin, let's focus on Bristol Hospital since we've been discussing it. And I'll direct your attention to the data that you have listed for calendar year 2019 in the category that you describe as Medicare fee-for-service, quote, rehab appropriate discharges. That number is 495, correct?
That is what's in the table, yes.
What can you tell OHS staff and Hearing Officer Yandow what the actual number of patients discharged from Bristol Hospital in calendar year 2019 were actually discharged to IRF care?
I do not have that.
Can you tell the hearing officer and OHS staff for Danbury Hospital, out of the 3,013 quote unquote rehab appropriate discharges that you list in your column, how many of those 3,000 quote unquote appropriate discharges for rehab care, how many of them were actually discharged into IRF facilities anywhere in the state of Connecticut?
I know the number of discharges. I know the number of admissions that Danbury Hospital accepted, which was just over 200. And I know that Danbury Hospital predominantly serves patients from its own hospital. So I can estimate around 200 of the 3,013 Medicare fee-for-service patients went to Danbury Hospital for IRF services. So a small percentage of that total, again, knowing the total 3,013 is only a portion of rehab appropriate patients.
Hartford Hospital, according to your 2024 projection, 66 patients who were discharged from Hartford Hospital are going to be filling up beds at Encompass Encompass Healthcare of Danbury. Looking at the calendar year 2019 data for Hartford Hospital, can you tell us how many patients discharged out of Hartford Hospital were discharged from acute care into inpatient rehabilitation facilities? What is the actual number?
I can look at their Hartford Hospital admissions and tell you how many patients they serve. What that will not tell me is how many came from the service area.
All right, thank you very much. Now, you have made very clear, I think, in your direct comments that from your perspective, the Encompass Danbury Hospital that's proposed will complement rather than compete with Danbury Hospital, which you acknowledge is the sole provider of inpatient rehabilitation facility services in the proposed service area, correct?
That is what I've said, yes, because of the array of services, for example, and the fact that
Could you direct your attention to page 74 of the CON application that you prepared? Do you have that in front of you?
page 74, yes.
In particular, I want to direct your attention to applicant table 12. Do you have that handy?
I do.
So with respect to just identifying applicant table 12, this shows the utilization rates for existing inpatient rehabilitation facility providers throughout the state of Connecticut, correct?
I wouldn't say it that way. It shows the occupancy rate. I would just clarify that it shows the occupancy rate for each provider. Yes. I mean, we're interchanging utilization and occupancy. I just wanted to be clear that it's the occupancy rate. Yes.
Applicant table 12, please tell me if I've not read correctly what your CON application says. It says utilization of existing inpatient rehab providers - Connecticut, correct?
That's correct. And the conclusion is the occupancy rate. Yes. We're saying the same thing. I've just talked about the use rates previously. So I wanted to be clear that we're focused on occupancy of units now.
So taking Danbury Hospital, which is at the top of the table 12 chart, this reflects actual data from fiscal year 2018, correct?
It actually is 2019, and I apologize, that's a typo. You see how to the right, I've got FY19 IRF average length of stay, and then I did not even include the full FY19 on the far right column. So my apologies, because it's not clear. This is all FY19 data.
And so that's fine. So this reflects actual experience for fiscal year 2019, correct?
That's correct.
And I believe you said at one point in your direct comments or direct testimony that Danbury Hospital was full up. In fiscal year 2019, Danbury Hospital's actual occupancy rate of its licensed beds was 74%, correct? 74.1%.
That's correct. 94.4% of the staffed beds, but 74.1% of licensed. That's correct.
100% of licensed beds and not 80% as recognized by the state facilities plan as optimal occupancy, correct?
For licensed beds, that is correct. It was far beyond the 80% for staffed beds.
Okay. And well, we know that based on the actual data that you've included in your chart for Danbury Hospital, the actual number of patients discharged into the inpatient rehabilitation facility to receive care was 272 cases, correct?
That's correct.
And you talked earlier, I believe, in response to a question from the hearing officer, that you are projecting that Encompass will be referred from Danbury Hospital a total of 117 patients in your first full year of operation 2024, correct?
That's correct. So those patients would be in addition to what Danbury is serving. That would help close that gap in care potential.
Right. And what data or chart can you point me to that shows at any time in the past 3 years, Danbury Hospital has referred 117 patients out of its facility because it lacked bed capacity to provide inpatient rehabilitation services.
I'm gonna object to the form, and I don't think that's the basis, is the lack of available bed capacity at Danbury Hospital. I'll let you
Well,
answer.
I'm going to overrule the objection. Because that is a question of mine, is how do we determine, bed need is key here. So part of the bed need would be that they were coming from Danbury. She earlier talked about a 94% capacity rate filled. So I'm going to allow the question.
Would you repeat it, please?
What I'm asking you is, what data or chart can you provide us with that shows that at any time in the past 3 calendar years, or at any time in the past, Danbury Hospital has found it necessary to refer 117 patients to some other facility for inpatient rehabilitation care because it did not have enough capacity in its 14 licensed beds?
I do not have data that shows that they have denied or not cared for this 117. What I have data showing is that a disproportionate number of patients in the area go to SNF, and I have physician letters referencing the need for patients to receive inpatient rehab that have not. But I cannot point you to the 117 because they're simply not getting the care now. They're not being referred anywhere.
How many physician letters do you have?
There are, I believe there are 3 letters and then a brain injury letter. So I would say 4 providers, but 3 physician letters.
And according to your projections, you expect 8% of your total patient census to come from physicians, correct? Physician referrals.
Well, I wouldn't agree with that statement because you're conflating the physician and hospital referrals. There's not a patient that is seen at an inpatient rehab facility that does not have a physician referral. So even if they come from the hospital, it is through a physician.
I apologize for my lack of clarity. Your own projections project that of the 40 beds that you propose will be occupied in this new facility, is my percentage correct that you project 8% of that census will come from physician office referrals?
Can you point us to the chart, Attorney Tucci, that you're referring to? Well, you're asking a specific question about percentages. It would appreciate it for my benefit if I can look at the chart while you're asking the question.
All right.
We can, but we should first see if she can answer the question.
Yes, if you look at, see on page 710, the 8% represents patients who come from physician offices rather than discharged directly from their hospital.
All right, so my memory is correct then, right?
That's correct. 8% come from physician offices.
All right, now, could I direct your attention back to the table 12 that you included in your CON response?
I'm there.
And in this chart, what you're showing to the Office of Healthcare Strategy are it's the existing landscape in Connecticut that shows who the inpatient rehab providers are in the state and what their experience is for fiscal year 2019, correct?
That's correct.
All right. And looking at the column titled Total Staffed IP Rehab Beds, you would agree with me that according to the data you're reporting, for the total number of inpatient rehabilitation facilities throughout the state of Connecticut, there are 159 staffed IP rehab beds, correct?
That is correct. And it's just for clarification of the record, you said what I'm reporting, I am summarizing in this table what came from the own hospitals reports. But yes, it's 159 for the 7 providers combined.
Right. And for the 7 providers, the total number of licensed beds is 167 throughout the state of Connecticut, right?
That is correct, based on the hospital's reporting, yes.
And the experience, actual experience that's recorded in your table 12 chart for the fiscal year of 2019 with respect to the occupancy of those 167 beds throughout the state of Connecticut is 68.8%, correct?
That's correct. And that's why, again, I keep talking about the gap in care, historical versus what I think it should be. But that 68.8% is based on FY19.
Okay. And so we know in 2019, there were 167 total available licensed beds in the state of Connecticut, right?
That is correct, with 14 of those within the geographic defined service.
And the 7 providers existing in the state of Connecticut managed to fill up approximately 68% of their beds, right?
That is what their utilization was. That is correct.
All right. Now, we spent some time earlier talking about the geographic area of central Connecticut, and you identify as one of the existing providers, Mount Sinai Rehab Hospital, which is located in Hartford, correct?
Yes, that's a freestanding IRF.
I'm sorry.
Yes, that is a freestanding IRF.
And Mount Sinai has 60 licensed beds and 60 staff beds. At least it reported that in fiscal year 2019, correct?
Yes, that report, just for the record to be responsive to your question, that data, they don't report their Form 400 to OHS. I went to a different source, which is noted in the table, AHD, American Hospital Directory, and that is what was provided there. They would not have a difference in staffed versus licensed in that report as you do in Connecticut.
And according to the data you found and you reported to OHS in the applicant table 12 that you have presented, Mount Sinai's actual experience in fiscal year 2019 with respect to its ability to fill up the 60 beds in its freestanding facility, it showed an actual experience of a 55.3% occupancy rate, correct?
Based on their data, yes, that's correct.
And you'd agree with me that Mount Sinai is located in central Connecticut?
It's in Hartford, a fair distance from the proposed project in Danbury, but it is in central Connecticut.
It's about 60 miles away, isn't it?
You cut out at the beginning.
In fact, it's about 60 miles away from where you propose to build this new hospital, right?
It's over an hour drive, so that sounds right.
Now, I believe it was your testimony, but if not, it was one of the other witnesses. You talked about how, in terms of the state-of-the-art care at this proposed facility and returning people to functionality, the worst outcome would be a situation where you had a patient in inpatient care for rehabilitation services, and then they had to go back to the acute care hospital that they were discharged to. That's a less than optimal result. Would you agree?
A readmission to following discharge from IRF is not desirable.
All right, could you go please to page 32 of your CON materials?
I'm there.
All right, and I believe this is a chart that you put up. Do you have it available?
Yes.
Yeah, he wants an screen. No. I don't believe we have it available unless you want to wait a few minutes. It's CON page 32. I have it in front of me. I don't know if you want it on screen or not.
Don't need to wait. So this is a chart that you prepared to show sort of what Encompass's national experience is in terms of where patients end up, correct?
I would not agree with the characterization of it. I did not prepare it. This actually comes from an Encompass annual report. And I know you'll continue asking me questions. I probably am not going to be the best person to address it, but it is addressing quality care. It is Encompass national data. And I did put it in the CON application.
National data that Encompass reports from its own experience is that for Q4 2019 and Q1 2020, with respect to that category of patients that it treated who had to be discharged back to an acute care hospital, it's just over 10% for both years, correct?
That's what's shown in the chart, yes.
All right.
Dr.
So-
Charbonneau would be better to address that.
I want to ask you about statistics. But we want to do some math here. Not my favorite subject, but we'll get through it. So let's now go to page 68 of the CON, table 10.
I'm there.
And this is this shows the payer mix projections for the total number of patients that Encompass projects it will treat for various fiscal years, correct?
That is correct.
And if we focus on year one, which is your fiscal year 2024 projection, you see that?
I do.
Your projection is that the Encompass Danbury facility will treat a total of 623 patients.
That is correct.
So applying Encompass's national experience to your projection of 623 patients, we would then reasonably expect that approximately 62 patients who were housed at the inpatient rehab facility that is proposed to be built to have to go back to an acute care hospital, correct?
Mathematically, you are correct. Dr. Charbonneau is better positioned to talk about the current discharge to acute care, if it's the same or lower, and any reasons why, but I totally agree with your math. 10% of 623 is 62 patients.
Back to an acute care hospital because they need care that can't be provided at an inpatient rehabilitation facility, right?
This is following discharge. So again, Dr. Charbonneau is the best person because that is, it could have other medical morbidities that you're outside my lane on the clinical reasons that I am not the right person.
I'm not outside your lane with respect to the geography, and you would agree with me that the closest acute care general hospital to the facility that's being proposed here is Danbury Hospital, which is 4.5 miles away, correct?
That's correct. That's the closest hospital.
Could you now please turn your attention to the January 8th, 2021 completeness question response that was submitted on behalf of Encompass. And I'll give you a page reference in a moment. Direct your attention to page 000522.
Page 522.
Yes.
I'm there.
And in particular, I'm just asking you to focus on the question that Office of Healthcare Strategy asked with respect to an explanation concerning the projection that 90% of the proposed facilities rehabilitation volume referrals will come from acute care hospitals. That's, you see that question number 2?
I see that question, yes.
And as part of the response to that question, that goes to the chart that we spent some time looking at, where you list the various hospitals and the projected referrals from those hospitals, correct?
That's correct. And I believe I have several caveats in that response where I talked about estimated and mathematical exercise, but yes.
Right. And in response to question 2C asked by the Office of Healthcare Strategy about the ability of the applicant to quantify the referral volume from each of the 10 hospitals listed in the chart that we just looked at, the response that you prepared reads in part, quote, "It is impossible to meaningfully quantify the referral volume expected from each referring hospital because referral patterns are driven by a number of factors," and so on. That's what you reported to OHS in response to that question, correct?
Correct, including the individual patient's needs and circumstances, the physician's patient mix, et cetera, as you see there on page 522.
Attorney Tucci, do you have an estimate on how long you have with questions?
5 minutes, 5-10 minutes.
Okay.
Can we now go to table 2 in your CON materials? And this is at page 14.
I'm there.
Help me make sure I understand what's being depicted in applicant table 2. This is data for 2018, is that correct?
That is correct. I presented 2019 earlier today, but you have 2018 on page CON 14, yes.
Right. And this is data that shows actual utilization in the area of Western Connecticut, which you've defined as Fairfield County and Litchfield County, per 1,000 discharges, is that correct?
That is correct. It's for residents who live in those two counties per 1,000 where they went I'm sorry, the utilization and how many went to your point, either inpatient rehab or general acute care.
The actual data for Western Connecticut shows is that for Fairfield and Litchfield County combined, there were a total of 7 cases for post-acute care services in Fairfield County and 4 per 1,000.
That is correct. I want the record to be a little bit clearer if I can be responsive to your question by saying, okay, by saying that, yes, it's for residents in Fairfield County, there were 7 discharges to inpatient rehab facility, 7 discharges per 1,000 Medicare fee-for-service beneficiaries, 4 IRF discharges per 1,000 Medicare fee-for-service discharges for Litchfield County residents.
And you also report there that the actual experience across Connecticut as an average is that the actual performance rate, if you will, is a discharge of 5 patients per 1,000 Medicare fee-for-service patients, correct?
Correct, which is why I mentioned it's among the lowest in the nation.
In order to make your bed need methodology that you went through in some detail in your direct testimony uses as the multiplier for the expected level of discharges per 1,000 Medicaid fee-for-service patients, the 75th percentile of the national rate of 13 per 1,000 discharges, correct?
That's correct. That
Not-
is, I would have.
Not,
Go ahead. That's fine.
not the national average of 11, correct?
That's correct.
And
the
not
reason I used
not the Connecticut average of 5, correct?
That's correct. I would not use the national average of 5 when I know that there is no reason for Connecticut to have such a disproportionately low IRF rate when, for example, you compare it to the benchmark of general acute care.
Of your pre-filed testimony, I believe you state, and you can refer to it to make sure I'm reading it correctly, quote, residents in Western Connecticut with too few IRF beds have IRF utilization rates significantly below that of the US national average.
What page are you on? I'm sorry.
Page 5 of your pre-filed testimony.
That is correct. The low utilization rate is reflective of too few beds, and the physician letters echo that or expound on that.
Can you please put up for us the chart that you showed earlier, which is the figurative representation of utilization in Fairfield and Litchfield counties? I believe it's figure 3 at page 17.
Exhibit C, page 6.
Yeah, the chart. That's it. So this chart shows what you've plotted out as the experience in Fairfield and Litchfield County, and then the Connecticut average. And I want to focus on the years 27 through 2011. Do you see those years?
I do.
You're showing a national average of 11 So that's 11 cases per 1,000 Medicare fee-for-service beneficiaries, right? 11 per 1,000 get IRF care, right?
That is correct.
And it shows that for Fairfield County for 2007 through 2011, for Fairfield County, the residents in that county were operating at just a little bit under the national average, showing 10 patients per 1,000 Medicare fee-for-service beneficiaries receiving IRF care, correct?
That is correct.
Are you aware of whether there were any more beds in IRF licensed beds in Connecticut in 2007 through 2011 than there are today?
My understanding is that I think Bridgeport consolidated and moved beds. And if my understanding is correct, then that really makes my point that when you don't have the local available accessible IRF beds, then that utilization drops. And that's why my position is that as you have such low utilization, it is illustrative and documents that there are too few beds. If the beds aren't there, the patients will not be able to access them and use them. Danbury's own position talks about proximity and patients choosing SNF over IRF because of closeness. So my understanding is that there was consolidation and closure of beds in Fairfield County.
What data have you presented about closure of beds in Fairfield County in 2007, 2008, 2009, or 2010?
I did not go back and talk about the closure of beds to change the utilization pattern from 10 to where it is now at 7.
So with respect to the table you presented, sort of the mathematical bed need projection that you did, in order to satisfy yourself and Encompass that there was a sufficient need to add 40 additional beds to the Western Connecticut service area, you have adopted what you have discussed as a population-based methodology, correct?
I would take issue with the characterization of satisfying myself, but I have used a population-based methodology. That's correct. That has been accepted in multiple states.
And that's the methodology that is reflected in the calculations you performed in Table 3, correct?
Yes, which is CON page 23 for the record.
You indicate in your pre-file testimony that this population-based methodology formula that you are using has been approved in several states, Connecticut not being among the states you've listed, right?
That's correct. I do not believe that there's been an application in Connecticut, so there's not been an approval, nor to my knowledge has there been a denial either. This presentation of Table 3, I believe, is new.
In fact, I believe, if I heard you correctly in your direct testimony, you've made quite clear that the methodology that Encompass Health is using in its CON, quote, differs fundamentally from the OHS methodology. Those are the words you used, correct?
Of course, because what I'm looking at is to close a gap in care, and what OHS has per the state health plan mathematically is to look at the historical utilization. So either you accept status quo, which is what OHS's methodology is based on, or you recognize a gap in care, which is what my methodology is based on. So because of that, there is a fundamental difference.
I want to talk now about commentary that you have made during your remarks today and in your pre-file testimony concerning patients who are receiving suboptimal care because they are being housed in skilled nursing facilities. In particular, I want to direct your attention to your pre-filed testimony at page 2.
Page what? I'm sorry.
Which page? Page 2? Sorry, can't hear you.
All right, page 2. Now you see the sentence that you've written there beginning the service area.
I do see that.
And you say, quote, the service area, and there you're referring to the proposed 52 zip code Western Connecticut service area.
That is correct.
The service area has a substantial deficit of inpatient rehabilitation beds, comma, which is leading to many patients who qualify for this level of care receiving suboptimal care at skilled nursing facilities. Have I read that correctly?
You have read it correctly, yes.
And now, would you please turn your attention to Encompass's response, 2020 response, completeness question response. And I'm referring to the October 16th, 2020 response. And let me direct your attention to page 486.
Page what? Okay.
486.
Okay.
And here, the Office of Healthcare Strategy is asking a question about the ability to quantify the number or percentage of patients in various categories, including category of those patients who are receiving care in a skilled nursing facility that you identify as being more properly patients who should be getting IRF care. That's the gist of the question that OHS was looking for information on, correct?
Let me read it, please. Yes, I would agree with your statement.
Right. And in providing a response to this question, Encompass has agreed in essence that there is really no reliable way to quantify the number of patients who purportedly are in SNF care who should, in Encompass's view, be receiving IRF care, correct?
I would agree with that to the extent that I don't have a database I can point to. The physicians talk about their experience, but we've not quantified that.
The 3 doctors that you have letters from?
I'm sorry, I could not hear you.
The 3 doctors that you have letters from, that's what you're talking about?
Yes, that represent large groups and multiple physicians.
To be specific, the response that Encompass has given to OHS on this topic of what percentage or number of patients who are in the category of getting care at skilled nursing facilities, which you say is being utilized higher than the national average, your answer is, quote, the extent to which patients will be referred from general acute care hospitals to Encompass Danbury instead of to each of the aforementioned categories, which includes SNF, quote, is not quantifiable, end quote, correct?
That is correct. And to be responsive to your question, when you're talking about that I'm purportedly talking about the SNF patients, that's not my data, that's CMS data. And Connecticut and Western Connecticut are significantly above the national average. So I do take issue with it. It's not my data. It's the fact of the matter. and it's 140% for Fairfield and Litchfield County. Disproportionately high to SNP and disproportionately low to IRF.
Appreciate your time.
Is that your cross?
Yes, it is.
Okay, redirect.
Yeah, if you could give me one second. See, if you could just give me 1 second to regroup with you. Oh, yeah. Okay, I'm sorry about that. I just have a few questions, a very few questions, bringing you back, Ms. Chafin, to those initial questions about transfer agreements. Can you explain again for Attorney Yondo and OHS staff, just so it's clear what a transfer agreement is and which patients it pertains to?
Yes, the transfer agreement is distinct from a referral into the inpatient rehab facility. A transfer agreement is for an existing provider who is offering service and has an existing patient, and that patient needs to be transferred to a general acute care hospital.
Okay, so a transfer agreement doesn't have anything to do with referring patients into an IRF or IRF services, correct?
That's correct, which is why the transfer agreement is not developed now and it would only be established once the project is under construction.
I have no further questions. That's it. Thank you.
Okay, thank you. Attorney Tucci, do you have cross of the other witnesses? Excuse me? I think you're on mute.
No, thank you very much.
No, okay. So the witnesses, I would like them to, they're not excused because we do have questions from OHS coming later on. We do want to get through the intervener before OHS asks us questions, because we certainly don't want to be repetitive. So, okay, so that we are done then with the applicant's evidence. I appreciate everyone's time on that. For the intervener, Attorney Tucci, are you the one still the lead here?
Still me.
Still lead, okay, I just wanted to, you had 3 appearances in, so I just, okay, do you want to, we'll start with an opening argument.
Yes, thank you very much. On behalf of the intervener Danbury Hospital, this is Ted Tucci. And first of all, let me just express appreciation on behalf of Danbury Hospital for the opportunity to participate in these proceedings, and also to share Danbury Hospital's perspective as the sole provider of inpatient rehabilitation services in the Danbury service area with respect to this proposal. Now, to be clear, what we're talking about here is an application by Encompass Health to build a brand new hospital at an estimated cost of just under $39 million in order to bring 40 new beds into the Western Connecticut service area. If you look at that proposal, it doesn't take too much math skill to determine that that is a cost of about $977,000 per bed. In Danbury Hospital's view, and what you'll hear from the witnesses today, is that this application represents a classic example of a proposed solution in search of a problem that doesn't exist. Stated very simply, the Encompass's repeated statements over and over and over again, no matter how much they say them, that there's a gap in care for Western Connecticut residents, simply does not exist. It's nothing more than an illusion. The applicants ask the Office of Healthcare strategy to believe that they're uniquely suited to meet the anticipated future need for more IR bed capacity in the service area. But that simply isn't the case. You're going to hear from Sharon Adams, who's the president of Danbury Hospital, that Danbury Hospital, which has an existing IRF facility of 14 beds, has more than ample financial resources and also the capacity to expand its existing 14-bed unit to accommodate any reasonable anticipated growth in demand as a result of aging population in the service area or in Connecticut in general. The applicants asked OHS to believe that existing providers of intensive rehabilitation services in Connecticut, like Danbury Hospital, focus on a limited number of clinical conditions. That simply is not correct. You're going to hear from Dr. Beth Aronson, who is the medical director of the inpatient rehabilitation unit at Danbury Hospital, and who has 27 years of experience caring for patients in her hospital. At Danbury Hospital has a full complement of care specialists and a full array of equipment and services to provide comprehensive therapeutic services that address all the impairment diagnoses that you would expect for rehabilitation services. The applicants ask OHS to believe that the reason that Connecticut's average utilization rates for inpatient rehabilitation are less than the national average, or should be at some target percentage of 13, is because patients who want or need inpatient rehabilitation care simply can't get a bed anywhere in the state of Connecticut. That is simply not correct. We've already seen it from the data that the applicant has provided. But more than that, you'll actually hear from somebody who has boots on the ground experience. You'll hear testimony from Dr. Aparna Oltekar, who's a board certified internal medicine doctor and who practices hospital medicine at Danbury Hospital. And she'll testify that Danbury Hospital has adequate bed capacity to meet her patients' needs when she needs to refer them for inpatient rehabilitation care, and that her actual experience in the service area as a doctor who treats patients is much more reliable than national statistics. When all the evidence is in, Danbury Hospital is going to ask OHS to conclude that this is a costly proposal to add capacity for undemonstrated need, and it fails to satisfy the CON requirements, and frankly, represents a bad healthcare public policy choice for the citizens of the state of Connecticut. Thank you.
All right, Attorney Tucci, your witnesses today, I know we have 3 of the pre-filed. If you could state their names for me.
Yes, so the first witness who will be offering testimony is Sharon Adams, last name A-D-A-M-S. You will then, hearing Officer Yando, you will then hear from Dr. Beth Aronson, capital A-A-R-O-N-S-O-N. And then finally, our presentation will conclude with testimony from Dr. Aparna Oltekar, O-L-T-I-K-A-R.
Are they there with you, or are they each separately on a remote?
They should be coming up now. You see the Danbury Hospital indicator on the screen.
Hi, I'm Sharon Adams.
Okay. All right, can you raise your right hand, please? Do you solemnly swear that the testimony you're about to give and the pre-filed testimony that you filed in this matter is the truth, the whole truth, and nothing but the truth, so help you God?
I do.
And do you adopt the testimony that the pre-filed testimony that is dated October 27th, 2021?
I do.
And again, could you state your name for the record?
Sharon Adams, A-D-A-M-S.
Okay. All right, Attorney Tucci, we do have the pre-file. We have gone through, we've read it. So I don't know if your presentation is for her to reread her pre-file or anything brief.
No, I think I can clarify. Consistent with my earlier remarks, we anticipate that our total presentation time would take about 15 minutes. And the intent of our witnesses is to provide a very high-level summary to add color and flavor to their pre-file testimony rather than simply rereading what's already there.
Okay, I would appreciate that because we do have it and we do read it. We go through everything with a fine tooth comb. So with this witness, since we have Sharon Adams on, is there, Ms. Adams on, do you have some follow-up questions or do you want her to make some sort of statement?
Ms. Adams is prepared to provide a very high-level summary of the information that she'd like to communicate to you right now.
Okay, thank you. You can go ahead.
Thank you. Good afternoon, Hearing Officer Yando and staff of the Office Health Strategy. First, let me thank you for allowing me to testify today. As I've said, my name is Sharon Adams. Danbury Hospital currently operates a 14-bed inpatient rehabilitation unit that is physically integrated into Danbury Hospital. And you've heard it's clinically integrated with New Vance Health System. It does maintain an approximate average daily census of 11. For over 35 years, the inpatient rehabilitation clinical team has been providing comprehensive healthcare, quality care that meets the needs and preferences of our patients and families within the Danbury community. Throughout these years, the physicians, clinical teams, alongside patients and families, have been determining what is the best place for that transitioning care that not only meets the patient's clinical, functional needs and psychosocial needs, but also keeping in mind the patient's and family's preference. We are committed to providing that high quality and cost-effective inpatient rehabilitation care as a component of the full continuum that you've heard that we provide throughout New Vance Health, included the extended rehab care, the outpatient rehab and physical medicine, as well as a very complex home care. A proposal to spend nearly $39 million to add 40 new inpatient rehab beds to a Danbury service area is not justified from a quality of care or a cost perspective, especially at a time now when we are so focused intently on controlling the cost of delivering high quality care, as well as a challenge with a national and statewide healthcare worker shortage. A proposal to build a new freestanding hospital that triples capacity in a service area all at once is not responsible choice. When the need for expanded capacity to provide inpatient rehabilitation arises, we have those resources and capacity to grow our unit in a responsible and a cost-effective way to meet our patient communities. And why should it not be Danbury Hospital? We've been providing those cares for 35 years. We've been the one meeting the community needs for all those years. Furthermore, it's important to point out the applicant's projection of volume to fill up the 40 beds of the new hospital do not reflect the actual utilization that's been the experience that we've been experiencing throughout the service area, and do rely heavily on the New Vance Health referrals. In my view, as someone with years of clinical and executive experience in healthcare, relying solely on national averages for inpatient rehabilitation utilization cannot justify that need, let alone account for the characteristics of circumstances affecting the Danbury service area. Finally, as you've heard, the proposal threatens the stability of Danbury Hospital as the existing nonprofit provider for inpatient rehabilitation services in the area. The applicant believes that adding 40 new inpatient rehab beds, approximately 4 miles, will not take away existing patient volume from our hospital. That is not realistic. As a nonprofit hospital, Danbury Hospital has been proud to meet healthcare needs of the community residents regardless of our ability to pay. The proposal here is geared toward capturing the higher generating cases in our service areas, which will adversely affect Danbury Hospital, therefore impacting our most vulnerable patients and their families who rely on Danbury Hospital's doors to remain open to them. On behalf of Danbury Hospital, I respectfully ask the Officer of Health Strategy to reject this application, because there is no need for it and it is not in the best interest of our patients in Western Connecticut. Thank you for the opportunity.
Okay, thank you. Attorney Tucci, your next witness, please.
Mr. Yando, I now ask Dr. Aronson to come to the microphone.
Hello, Dr. Aronson. I'm sorry.
No, you, go ahead, I'm sorry. Whenever
Okay,
you're ready.
All right, Dr. Erickson. Hi, I'm Joanne Yando. I'm the hearing officer in this matter. Could you raise your right hand, please? I'm going to swear you in. You solemnly swear that the testimony you're about to give in this matter, along with the pre-filed testimony you filed on October 27th, 2021, is the truth, the whole truth, and nothing but the truth, so help you God?
I do.
And do you adopt the testimony that was the pre-filed testimony that you signed and filed?
Yes, I do.
Okay, thank you. Attorney Tucci, do you have questions or is there a presentation?
No, yeah, again, thank you, Hearing Officer Yando. Dr. Erickson is prepared to deliver a summary of her remarks and testimony.
You can go ahead, Dr. Aronson.
Thank you, Hearing Officer Yandel and staff of the Office of Health Strategy for allowing me to testify today. My name is Beth Aronson, and I am the Medical Director of the Inpatient Rehabilitation Unit at Danbury Hospital. I adopt my pre-filed testimony for the record. Let me start by saying that the Danbury Hospital Rehabilitation Unit already provides high-quality, intensive-level rehabilitation. We have a 14-bed unit. We have an extremely dedicated staff with very low turnover. That's one of the major reasons I've been at Danbury Hospital for 27 years. On the rehab unit, we provide individualized and patient-centered, as well as family-centered care. We spend time training and educating family regarding patients' care needs. We have the full complement of rehab services. We have certified rehab nurses, physical therapists, occupational therapists, speech therapists, cognitive therapy, recreational therapy, social workers, and discharge planners. Our census can be variable and is directly related to hospital census. We rarely have a waiting list or need to turn patients away. Patients rarely have to leave the area for specialty rehab care. We are capable of handling a multitude of diagnoses, from strokes, spinal cord injuries, amputations, multi-trauma, brain injury, cardiovascular disease, cancer rehabilitation, one of my areas of expertise, pulmonary conditions, and fractures. In fact, we and all other intensive rehab facilities have to make sure we are compliant with Medicare's 60% rule, where 60% of patients need to have one of 13 qualifying conditions. About 10% of our patients come from outside hospitals, when they're usually returning to their home community after a specialized surgery or a major medical or surgical event when they're out of town. We've had patients as far from Europe, as well as Florida and Cape Cod. We have a nice referral stream from Columbia Presbyterian, as well as Yale, for patients who go there for specialized surgical procedures. They know they can trust us as their rehabilitation unit of choice. We do get referrals from around the state. Usually these referrals are patients with specialized issues, such as having an unsafe discharge plan, major drug addiction issues, or they were not accepted by any local rehab unit due to lack of insurance or not appropriate for intensive level rehab care. Our patient satisfaction remains consistently high. We recently received a very generous gift from a patient who sustained a hip fracture and had complications related to bleeding. He was very grateful for the excellent nursing and therapy care, as well as the responsiveness of all the staff members. One of our roles in the hospital is to function as a consultant to many patients in need of rehabilitation services in the hospital setting. We see patients very early on the hospitalization side, usually by day 2 or 3, and we get to know the patients and their families and make recommendations to the medical team regarding care and prevention of complications. We help to educate the house staff regarding the patient's needs. We are not screeners, just scouting to fill beds. Seeing patients early allows us to detect subtle changes once on rehab, rather than be a complete unknown entity once they're transferred to an outside rehab facility. For an inpatient rehabilitation stay, we have to assess these patients carefully. First and foremost, we consider their functional needs as well as their medical needs. We determine, do they need daily monitoring by a physician? Can they tolerate the intensity of 3 hours of therapy a day? We also determine, do they need round-the-clock nursing, which is a requirement also for intensive rehab, as opposed to skilled nursing facility level of care. We assess medical stability, tolerance for 3 hours, and ability to fully participate and make reasonable functional gains. If someone's not going to be able to make gains and be able potentially to go home, then they may not be appropriate for our level of rehabilitation care. We also review the patient's psychosocial issues and resources as well. We help the patient and the family decide the best level of rehab care depending on the stage of their illness, their tolerance for rehabilitation, as well as recommendations from the referring or treating care team players. Geography is important. Patients and families don't want to travel too far. Visitation is extremely important, and participating in the patient's care and get training is also extremely important. Sometimes patients will actually forego an intensive rehab unit opportunity to get closer to home and stay at an extended care facility as a result. We are cautious regarding taking patients that are functionally too good or medically uncomplicated or can be appropriately managed at another level of care. These patients can potentially be retrospectively denied by Medicare. We work closely with hospitalists and specialists. They are very conscientious in their follow-up of our patients and in the co-management of these patients once on the rehab unit. Our three greatest obstacles regarding filling beds are geography, insurance denials, particularly managed Medicare, and regulatory intervention, with less and less patients being approved for intensive rehab level care. CMS has strict admission criteria. IRF volume has dropped significantly over the past few years due to regulatory interventions. In the community, it is rare for a physician to leave their busy office to take care of patients in outside facilities. I know this firsthand, having done consultations at many of the extended care facilities. Because we work hand in hand with our hospital doctors who already know our patients well, our patients get the attention they need on a timely basis. In conclusion, the rehab unit at Danbury Hospital already provides optimal quality rehabilitation care to patients in Danbury and the surrounding communities. We already meet the needs of the community at large, both in the inpatient and outpatient arenas. In my 27 years of experience, patients rarely want to leave their community for rehab care. As a rehab unit, we help to reduce length of stay for the hospital. We reduce complications. We provide ready access to hospital-related services, including radiology, internal medicine, surgery, and specialist care. We are also mindful of the trend to decrease healthcare costs and overutilization of inappropriate levels of care. We help reduce readmissions to the hospital and prevent unnecessary ER visits by being hospital-based. We optimize the continuum of care by ready access to the system-wide electronic health record and by following patients from acute hospitalization to rehab to home. We continue to stand poised and ready to expand the unit as needed. We're in the process of hiring screeners in our affiliated hospitals where there are limited rehabilitation consultation services, which will help optimize census and continue to provide care to those in need. Thank you.
Thank you. Attorney Tucci, anything else of this witness?
Hearing officer.
Okay, and I do want the witnesses to be aware. So Dr. Aronson, and I hope Ms. Adams is still around because there may be cross-examination. So are they still, I just wanted to make sure they don't go too far. Okay, and also there will be questioning from the OHS team. So they need to be available. Okay, we'll call you next witness, please.
This is Dr. Aparna Oltekar. She's now on screen, and let me introduce her to you, hearing officer Yandau, and she will again provide you with some high-level commentary based on her pre-file testimony.
Okay, hello, Dr. Oltekar.
Hello, hearing officer Yandau. I'm sorry, we just are logging back into this computer. I apologize for the delay.
Oh, that's okay. I think we can see you, we can hear you.
Okay.
I'm going to swear you in. Are you ready or?
I am ready. Thank you.
Okay, could you raise your right hand, please? Do you solemnly swear that the testimony you're about to give in this matter, along with the pre-filed testimony that you filed on October 27, 2021, is the truth, the whole truth, and nothing but the truth to help you God?
I do.
And do you adopt the pre-filed testimony that was filed and is in the record?
Yes, I do.
Okay, great. So I understand you have a small presentation. We've read the filed testimony, and then when you're done, there may be cross-examination. I just don't want you to go too far.
Okay.
All right.
Could I just have your spelling, Dr. Altekar? Sorry to be.
Sure.
I'm sorry. Yes, first name and last name, please.
Sure. My first name is A-P-A-R-N as in Nancy A, and the last name is O-L-T as in Thomas I-K-A-R.
Thank you very
All right.
much.
You're welcome. So good afternoon, Hearing Officer Yandao and staff of the Office of Health Strategy. And thank you again for allowing me to testify today. So as I've stated, my name is Aparna Oltekar, and I am the Vice President of Medical Affairs and the Chair of the Department of Medicine at Danbury Hospital. I have been practicing hospital medicine in the state of Connecticut for 23 years, the past 13 of which have been at Danbury Hospital. I have been the chair of medicine at Danbury Hospital for the past 6 years and VPMA for almost 2. The purpose of my testimony today is twofold: to share my experience as a practicing hospitalist who has frequent interaction with the inpatient rehab unit at Danbury Hospital, and to share my experience as a senior clinical leader at Danbury Hospital. In my role as a hospitalist, I am responsible for discharging patients from the acute care setting to the next appropriate level of care, which, based on the patient's medical condition and needs, can include inpatient rehab, subacute rehab, or home care services. In my roles as chair of medicine and VPMA, I am one of the key individuals at Danbury Hospital responsible for managing our length of stay. To do this effectively, I must understand all barriers to discharge being experienced not only by my personal patients, but by all patients admitted to Danbury Hospital. To gain this understanding, I meet several times a week with my chiefs of hospital medicine, critical care medicine, et cetera. I regularly attend multidisciplinary rounds on our inpatient units, and I chair the hospital's utilization review committee. In my experience, both as an extremely experienced hospitalist in the state of Connecticut and as a senior clinical leader at Danbury Hospital, bed availability is not the primary barrier to patients who require discharge to inpatient rehab in the Danbury Hospital service area. In my experience, the most common reason for patients at Danbury Hospital not having access to inpatient rehab services after their discharge is denial of coverage by the patient's insurance company, or in other words, lack of prior authorization. In my experience, again, both as a hospitalist and as a senior clinical leader, another significant barrier to patients being discharged to inpatient rehab is that they are not eligible for these services based on their medical condition. As you likely know, the average age in Connecticut is higher, significantly higher than the national average. And with advancing age come multiple comorbidities. As a result, many of our patients at Danbury Hospital are simply too sick and or too frail at the time of their discharge to tolerate the intensity and duration of the multimodal rehabilitation services that they would need to participate in on any inpatient rehab unit. As a result, contrary to the applicant's projections, I do not feel it is realistic to assume that in 2024, Danbury Hospital will generate a referral volume of 117 eligible patients who cannot get IR in our own unit. I also have concerns about care disruption and cost effectiveness if 40 new IR beds are added to the Danbury Hospital service area. Patients who require inpatient rehab services after discharge are generally medically complex, and in my experience, very frequently, they require medical and subspecialty consultation while they are receiving inpatient rehab services to manage their ongoing medical needs. So, as a hospitalist, I'm often called to consult on patients on the inpatient rehab unit at Danbury Hospital to treat their medical conditions. Given the real-world demands of medical practice, it is not realistic to assume that treating physicians will be able to provide on-site consultative services at a new facility not connected to Danbury Hospital. In other words, while the applicant may have an open medical staff model, it seems unlikely that the majority of my hospitalist and subspecialty colleagues will avail themselves of that model due to the extraordinary pressures facing all clinicians these days. This will be particularly true for patients being referred from geographically more distant hospitals in the proposed service area, such as Hartford and Bristol, on which the applicant's volume projections are predicated. As a result, it seems very probable or possible that the applicant's patients may not have the level of on-site medical and subspecialty follow-up that the complexity of their medical condition demands. The most likely end result of this will be that the Danbury Hospital ED, which is the closest ED to the proposed site, will become the safety net for such patients in the event of clinical decompensation. This will place a greater burden on our ED, which is already struggling with high volumes, rising acuity, and staffing shortages. In conclusion, I would like to say the Danbury Hospital serves its community by providing all patients, including the most vulnerable, with care across the clinical continuum. It is also part of Nuvance Health, which is an evolving integrated care network utilizing a common electronic medical record, a network service line approach, and other initiatives to coordinate care and adopt population health strategies. Carving out IR services or inpatient rehab services from this care continuum will potentially compromise the quality and safety of patient care and threaten the financial viability of Danbury Hospital, which has been faithfully serving its community as a safety net provider for over 100 years. On behalf of Danbury Hospital, I therefore respectfully ask OHS to reject this application, which I do not believe will bring better or more cost-effective healthcare to Western Connecticut residents. Thank you.
Attorney Tucci, anything else? You're on mute.
Sorry. Thank you.
I did the same thing.
That concludes the presentation on behalf of Danbury Hospital. Thank you very much.
Okay, you're welcome. Okay, Attorney Fusco, I'll let you call them in the order you want on cross-examination.
Sure.
We will, I'll allow a little some redirect after your cross on each witness, okay?
Okay, and I don't, in the interest of time, I know it's getting late in the day. I'm going to keep my cross fairly short, but I will start with Ms. Adams if I can. Let's go in order. I think you're there. I can mostly see you while we haven't speak of you. Are you there?
I'm here.
Yes.
Sorry.
Yeah, when she talks, you have to on speaker, so
Gotcha.
you can either put it on gallery and see everyone. I had to get a lesson in this, or when they speak, you talk.
That's fine. I can see you. I can see you over to the side. Thanks.
Are you able to hear me?
I am able to hear you well. Thank you. So Ms. Adams, I just want to ask you a few questions about Danbury Hospital's proposed expansion of its IR unit. If you can turn to page 6 of your pre-file testimony. On page 6 at the bottom, you mentioned that as part of its fiscal year 2022 budget, Danbury has allocated up to $3 million to renovate and expand the IR unit as needed to meet the needs of our community. Is that correct?
Sure, 1 second. Sorry, I'm just getting the right page. Yes, that's correct.
And I don't know if you have this in front of you, but your colleague, Dr. Aronson, sort of took that concept a step further and on page 21 of her testimony and said, Nuvance Health has prioritized an expansion of the inpatient rehabilitation unit in fiscal year 2022. Are you aware that that's what she testified?
1 second, I'm just confirming it.
No, that's fine.
Yes, I see it on page 5.
Okay. So my first question for you is, when did Danbury Hospital actually allocate these funds for its 2022 budget? Like, when was the budget approved?
The budget was approved a couple of months ago for preparing for our October fiscal year.
Okay, so it was approved in 2021?
Mhm.
Okay, so it was approved after Encompass filed its CON application in August of 2020 for a 40-bed inpatient rehabilitation facility, is that correct?
That's because that's how our fiscal year
Well,
transforms for our,
Understood, but we filed our CON application, it sounds like almost a full year before you budgeted the money to expand your unit, is that correct? We filed it on August 14th, 2020.
but we had other, I would have to look, but I think we have other things in process prior to that for the rehab unit.
Okay,
So I
but
would,
this $3 million budgeted expansion came within the last several months in 2021.
it was presented to the fiscal budget.
Okay. And would you agree that that then came after a letter that was sent to the Office of Health Strategy in November of 2020 regarding Encompass's proposal? It was sent by Sally Herlihy saying that Encompass's proposal was unnecessary and that Danbury Hospital had additional capacity to meet the IR needs in the service area.
Can you explain to me what I'm asking to agree to? I'm sorry.
I'm asking you whether after your hospital submitted a letter to OHS in November of 2020 saying that our hospital wasn't needed because you had sufficient rehab capacity to meet the needs of the market, you then decided that there was a need to expand your rehab capacity after representing to the agency that you had ample capacity to meet the need.
I can only verify to you when we actually presented approval for the $3 million fiscal year renovation. I can't per se go back chronologically and say when we actually started the other approvals and when they linked to that time frame of the letter that you're saying.
Okay, but
because what I'm saying is there may have been other steps ahead of time in our process. The $3 million renovation that we did for this capital year, there are other steps that we do in our capital years ahead of time. And what you're asking me to do is refer to the letter and the timing. And I can't validate that there weren't other steps ahead of time in capital years prior that had to do with an expansion that may have been. So I can only,
go ahead.
I can only validate that this fiscal year for 22, we approved the $3 million expansion.
Okay. Would it be fast? I'll ask it another way. Would it be fair to say then that when that letter was sent to OHS in November of 2022, when you said, and I'll quote the letter just so I don't misstate it. Oh, I'm sorry, not 2022, 2020. So on November 25th, 2020, you said Danbury Hospital's longstanding inpatient rehabilitation service has additional capacity to meet the inpatient need in the service area. Okay, so at that time, can she not hear me? Are we frozen?
No, that's all right. I couldn't. Sorry, go ahead. Please repeat yourself.
So at the time you wrote the letter, or that Sally Herlihy from your office wrote the letter in November of 2020 saying that Danbury has additional capacity to meet the need for IR services. You were referring to your current capacity. You did not mention anywhere in this letter that a planned expansion was in the works, did you?
I did not mention in the letter that there was a planned expansion. That does not mean I there wasn't anything in the process. There wasn't anything in the letter. You're correct. And we were in the process at that time, if I remember correctly. We were right in the middle of COVID, if I remember correctly, if the timing is correct.
But I mean, you took the time to write a letter about the project, and the project does, it's a yes, no question. You took the time to write the letter, and the letter doesn't mention the proposed expansion.
You're right, the letter does not mention that.
And as we sit here today and we look at your testimony, and again, if you look at, I believe it's on page 6, you say that Danbury Hospital provides integrated inpatient and outpatient rehab services in a coordinated care setting and already meets the need for inpatient rehab services in Western Connecticut. So you're saying there's no unmet need right now. You're meeting that need, correct?
Would you like to tell me what page you're referring to? I apologize. Did you say?
Page 6, the bottom. Right below the Roman numeral 2. It's the first sentence.
You're referring to my,
Yep.
sorry.
You're
You're referring to my pre-filed testimony?
Mm-hmm. Page 6 at the bottom. It's the paragraph that starts "as you will learn."
And you just said that in that sentence, you said that Danbury has been meeting. Where did you just read the sentence of it?
Yeah, the third line down, it says, you'd have to go up, Danbury Hospital from the first line, already meets the need for inpatient rehabilitation services in Western Connecticut.
Yes, I read it. I see it. Yes, I'm sorry. I apologize.
Did you participate in drafting your pre-file testimony and review your pre-file testimony before it was submitted?
Yes.
Okay, so that sentence, based upon that sentence, you're saying you already meet the need, that there is no unmet need for inpatient rehabilitation services at the current moment in Western Connecticut. Is that correct?
Yes.
Okay, and consistent with your position that there's no unmet need, you're only, at least according to the Forms 500 I looked at, you're only staffing 9 of your 14 rehab beds?
We're staffing 11.
Okay, so you're now staffing 11, but you're not staffing all of your rehab beds, correct?
We're staffing for an average daily census of 11. We can go up to 14.
So you staff 11 beds for an ABC of 11?
We have the flexibility to go up because we have an average daily census. So we have the flexibility, as I think most people do. We have the ability to flex up and down.
Do you have the ability to flex up and down on a daily basis if need be?
Yeah.
Okay. But you are only currently staffing 11 of them. And is that down, if I looked at the forms correctly, is that down from staffing 12 rehab beds in 2017 and 2018?
No, I think what it is that based on an average daily census, we staff up and down. We have the flexibility. That's how we've staffed, get per diem staff and have the flexibility to staff up and down.
How do you then report to OHS at the end of the year for that Form 400, how many beds you staff if you flex up and down on a daily basis?
Sorry. I'm sorry, you paused for a moment. Can you repeat yourself? I'm sorry.
If you flex up and down on a daily basis, how do you report to OHS at year end on the number of beds that you staff?
Because what it is it's your average daily census. If you staff for 11 for your average daily census, we flex our staffing based every day on what our needs are for those patients. For an average daily census, if I have an average daily census of 11, then I'm going to staff for that 11. But if I come in and have a patient need of 12, then I'm going to have staffed for that 12.
Okay, so right now you're staffing for an average daily census of 11, correct?
Yes.
And, so we're talking, back to, we're talking about, your statement that there's no unmet need in the area. Consistent with that, and since we're talking about Newbont's health priorities here, is it consistent with that statement that there's no unmet need that Norwalk Hospital closed its 12-bed HERF in 2015?
Norwalk closed their bed my understanding was because they actually were having a difficult time having physician specialty recruitment. It was not necessarily just related to patient need.
Okay, but it's still your position that there's no unmet need, even with those 12 beds closed, correct?
Correct.
Right. So there's no unmet need in the service area, but
What?
Go ahead.
Go ahead, finish your statement and then I can.
So there's no unmet need in the service area, okay? And yet you are budgeting $3 million to expand a unit that your colleague said is happening in 2022. There's no unmet need. Are you building a 20-bed inpatient rehabilitation unit in 2022?
What we have said is we have the ability to meet the need of any census that arises. We have absolutely capital allocated. We have the ability and have the resources to expand. And yes, we have the ability to expand physically as well as financially, the ability to meet the needs.
Okay.
When it arises.
When it arises, okay. So when your colleague.
And it has been allocated.
Okay, the money's been allocated, but the statement, Newbont's Health has prioritized an expansion of the inpatient rehab in fiscal year 2022 would suggest to me that you are expanding that unit next year. Is that not accurate? Is it accurate?
That is accurate.
Okay, so you're expanding your inpatient rehabilitation unit, even though there's no unmet need in the area.
That we will be able to phase it in, absolutely.
Okay, so is it that you'll be able or that you'll actually be doing it? Because you're saying there is no unmet need, that you can meet all the capacity, and then a competitor has filed a CON application, and now you've allocated funds, and you're saying you're building out a unit to meet need that you're also saying doesn't exist. So are you building the unit, and is there need?
I'm saying that we have started the process and have dollars allocated to be able to start an expansion of the rehab unit.
Yeah. Is that all you've done? Have you done anything else? Do you have schematics? Have you hired an architect?
Yes, we have an architect. We have an architect. We've been looking at architects, absolutely.
Okay, you've been looking at architects, or do you have schematic drawings? I'm trying to figure out.
We have tentative schematic drawings, and then we are looking at architects.
Okay, so you're actively moving forward with a project to expand an inpatient rehabilitation unit in your hospital when you say there is no need for additional inpatient rehabilitation services in the area. Is that correct?
We said that we would be looking at expanding the rehabilitation unit. Yes.
Just a few more questions for you. Do you know, and OHS has noticed all of the forms 500, and I would expect you to have them printed out, but do you know how many licensed beds there are combined at the Connecticut Newbont's hospitals? I'm sure you know how many licensed beds Danbury has, correct?
Yes. For Newbont's, are you asking?
Yeah, for the Newbont's Connecticut hospital. So Danbury, Sharon, and Norwalk. I'm looking for their combined licensed bed capacity.
I don't have that off the top of my head.
So if I pointed you, and I'm trying not to testify, so please give me some latitude, but I'm going to try to help. I mean, there are forms 500 that are in the record of this matter that you may not have in front of you. One for Danbury Hospital shows that you have 456 licensed beds. Is that correct?
Let me check. That's correct.
Okay, and the one for Norwalk Hospital shows that Norwalk has 366 licensed beds. Is that correct?
Let me validate that.
While she's looking, I just want to say for the public who have signed to talk, the agenda had public comment for 3 p.m. We're still going on with our technical part of the hearing. I will reorder it so that closing arguments will happen after public comment, but we will finish up with this technical piece, which is finishing cross-examination of interveners' evidence, and then the Office of Health Strategies questions with a short break between before the Office of Health Strategies questions. So I do want the public aware that we're reordering the agenda. We will take the public comment after the evidentiary piece. I'm sorry, go, Attorney Fespa, you can go ahead.
Oh, sorry, I was just waiting. Ms. Adams, I don't know if she, I'm not sure if she has the forms.
Norwalk's 366, sorry.
Okay, that's correct. And then is Sharon 94, is that correct based on this form?
I think we have Sharon as 78.
78 licensed. There's a form 400 I have shows 96 licensed.
78 is adult. And there's
Okay,
16 bassinets
okay,
for a total of 94.
94, okay. So just using those larger numbers, and my math is not very good either, but when I add those three up, I get 916 total licensed beds for the Nuvon system hospitals in Connecticut. And am I correct, if you can answer this, that the only inpatient rehab beds at Nuvon's hospitals in Connecticut are in Danbury, correct? They're the 14 beds that are in your hospital? So that's, so you're muted, I think.
Sorry, in Connecticut.
Okay. Yes, okay. And so that's 14 out of 916 beds, which if I do the math correctly means that only 1.5% of Nuvon's Connecticut's licensed beds are inpatient rehab, correct? And based on that, would you agree that inpatient rehab is not a core service for the Nuvon system in Connecticut?
No, I don't agree with that. When you're looking at it as Nuvance, yes, but I am not looking at it for Nuvance. We're looking at it for Danbury. You're looking at it for 916 beds when we are sitting here talking about it for Danbury.
Well, in their beds, and I was going to ask these questions later, but their beds, for which a majority of your referrals come from Nuvance Connecticut hospitals, which is why I'm looking at it as a system, but we can move on. I just have one last question for you, which is you mentioned in your remarks before that you're concerned, and forgive me if I quote you wrong, I was just jotting it down, but you're concerned that the Encompass Danbury Hospital might jeopardize Danbury's ability to keep its doors open. Have you submitted any evidence to support the fact that this hospital could cause Danbury Hospital to need to close?
What I said, I think, and I think you did misquote me a little bit, but that's, I understand, was, and I think I'll just make sure I look at my own, was that I was concerned that we would end up taking, it would impact our earth doors.
Okay.
And it would be changing, it would be impacting our population for that.
Okay.
For the community.
Okay, but that wasn't what I heard, but assuming we're talking about your IRF services, the same question, like have you submitted any evidence to show that this hospital will cause Danbury Hospital to need to close its IR service.
No, and no, I have not. And what I was saying was because I think if you recall, what I was saying prior to it was because of the type of payer mix that we will be taking versus what you may be taking.
Okay, I have no further questions. Of Ms. Adams, thank you.
Thank you.
Redirect.
Ms. Adams, can you hear me?
I can, thank you.
This is Ted Tucci for the record. Ms. Adams, can you tell me whether Danbury Hospital is committed to responsible investment in the IRF to meet need as it is shown in the future?
Yes, we are.
Thank you.
Thank you.
Is that it? Anything else?
That's it.
That's it. And
You're muted, but I think you're asking me. I have no further cross. That's it. Thank you.
okay, how about, I mean, another witness?
Oh, do I have another witness?
No, on the interview.
No, I have no cross. Oh, no, I'm sorry. I have no crosses of the other witnesses. Sorry. It's been a long day.
Okay, so we're going to take a brief break, come back with the Office of Healthcare Strategies questions, and then move on to public comment. Closing argument will be after public comment. I believe at this time there are, I think it's four people signed up for public comment. So anyhow, we're going to take it's 3:12. I want to come back at 3:20. Okay. And don't forget to, for anyone who hasn't signed out, we continue to record during the break. Please turn off your audio and you can turn off your video also.
fine. I'll put it on, Marty, don't worry.
Mhm.
Attorney Fusco, all your witnesses are available? I can't hear you, you're muted.
I believe so. Is Dr. Charbonneau, are you on?
Yes, I'm here. I'm here.
Okay.
Okay, because how about Attorney Tucci? Are you there?
Hey, good afternoon. Sorry, hearing off hand out. We have Attorney Tucci returning just this second.
Okay, that's fine. I'll wait.
Thank you.
And for the public that have just tuned in, as I mentioned earlier, we did have to reorder the agenda because we're still taking on the evidentiary part, which is, we have questions now from the Office of Health Strategy, from the OHS staff, of the witnesses. We will reorder